Nilima, you can share your screen and then Chinmay can get started.
Yes, Chinmay ma'am. Yes.
Yes, can we just have the first slide, please? Nilima, just put this on full screen and put the brochure.
Make it full screen, Nilima.
It's a little slow, the system is a little, just bear with it.
So a very good afternoon to all of you who have joined at this hour. And it's really a privilege to welcome all of you on behalf of my co-conveners, Dr. Sita Pal and Dr. Upma Saxena. So I first of all, I thank the FOGSI ICOG, our president, Dr. Bhaskar Pal, and our ICOG chairperson, Sheila Mane ma'am, and our secretary, Dr. Pratik Tambe sir, for this opportunity of hosting this Masterclass on Placentology. Placenta is an extremely unique organ that connects the mother and the fetus, and studying about the placenta is one of the greatest joys in perinatology. Today, we will use these 3 hours to look through this placenta in different angles and dimensions and try and make the most of whatever we can get out of it. So, at the very outset, I would like to welcome our chairperson, Sheila Mane ma'am, to give us her introductory remarks.
Yeah, good afternoon, everybody. And I welcome once again on behalf of ICOG to all of you, as well as seniors. I think Madam Mandakini Meg is here, and everyone, those who have joined today. So all of us, we know that these master classes are so focused, and we thought of having it on placenta, and it was a Chinmay's thought. And we already released a book on placenta in East Zone UA FOGSI, and many of you have already contributed the chapters. So all of us, we know how important it is. And I welcome all the speakers today. Dr. Chitra Ganesh is not a FOGSIan. I welcome her. She is from Bangalore. And all others are our regular people, Dr. Sharmila, Dr. Vandana, then Dr. Upama, Dr. Prashant Acharya. Thank you, Dr. Prashant, for accepting our invitation, and Bela Bhatt and Sita, and all the chairpersons. So I welcome you all, and I wish to see that more and more people join. Oh, I think we have just jumped already. We have 144 attendance, and that's really...
Excuse me, ma'am. Ma'am, I think I can see Dr. Sunita Tandulwarkar, our past president here, and that's such a joy that she's joined, ma'am.
Madam Dr. Sunita Tandulwarkar, I would just like her to say a few words if she had joined. It's a
real
really
honor.
nice to see her. Madam Sunita, you can just say a few words.
So lovely to see you
honor
all.
for us. Oh, so nice to see you.
So
Thank you so
lovely
much,
to see you all.
Thank
Me and Chinmay, we have decided that I'll give a surprise appearance and just say hello to all of you.
That's so
Sheila,
nice.
you are rocking as a chairperson. Bhaskar's year is going fantabulous. And I'm seeing so many of all the FOGSI members and Uday and Mandakini, the past chairperson, Pratik, Shashibala, Upma, Sita, thank you for taking Mukta in AMOGS. You really help us. Sunita Singhal, lovely to see you, dear. Arupji, thank you so much.
Nice to see you.
Chinmay, my love for you is, timeless. And
Thank you so much, ma'am.
a galaxy of a love. I give it to you. And I don't have words. No, she said today for the first time I'm starting. You are not first time starting, you are rocking. When Sheila said it was 144 and now it's 174.
Thank
It's
you, ma'am. Thank you so much
beautiful.
for
It's
joining.
beautiful. I think we have also released E. We are on placenta, and I heard Sheila releasing on a placenta the book. That itself signifies the amount of reading we need to do on this organ. This organ is most important organ, and probably we always used to talk anything else in obstetrics than the placenta. So lovely so much, Chinmay, and all the best to you. And give my love to all. 185, 187. Oh my God.
Thank you.
Thank you, ma'am.
Fantastic.
Thank you so much.
Fantastic.
And thank you. You made our day, Sunita. Thank you.
I
Thank
know.
you.
And I'm
And
going to
madam.
miss you all in Goa because I'll be in Orissa. It's my ISAR Orissa
Oh,
conference, and I can't help it. Thank you so much. Have a great time.
Thank
thank
you.
you. So, as we are talking about placenta, I was just reading an article on placenta that the placenta is such a respectful organ, even though later on it becomes vestigial, but earlier days when the cord clamping was not there, okay, people never used to cut the cord, and it was called as a lotus delivery, and the placenta was covered in a bag with some herbs, so to see that, and it was kept by the side of the baby till the cord used to get separated. I think they were more wise. I think maybe so much of immunological factors were transported. And another thing, the respect to the placenta, some people still practice, they used to practice burying the placenta or cutting the cord and keeping it with them. So placenta is a very respectful organ, because of placenta we are there. Okay, or whatever we are there today is because of the placenta. That's what I can say. So, dear all, once again, welcome to this very focused masterclass on placenta. Over to you, Chinmay.
Thank you so much, ma'am. Thank you for taking on this interest in placenta because, like I said, that is the organ which joins the mother and the fetus, and therefore we thought that this was a good thrust that we can have in perinatology. And we will start, and we have our past chair, Dr. Lakshmi Shikande and Dr. Pratik Tambe, our secretary here. So I would just request ma'am and sir to just give a few introductory remarks, and then we'll move on to the first session chairs.
So I don't see Dr. Lakshmi. Is it okay for me to speak?
Yes, sir. Yes, sir.
Okay, so welcome everybody to this FOGSI ICOG Masterclass on Placentology. I congratulate the conveners, Dr. Chinmay Ratha, Dr. Sita Ramurthyapal, and Dr. Upma Saxena for putting together an excellent program. The scientific program promises to be a wonderful academic feast, and there is something in it for everybody. We have speakers from right across the country who are all eminent, eminent stalwarts and well known in their chosen field. I look forward to learning a lot myself from this masterclass, and back to the community. Over to you.
Thank you. Thank you so much, sir. So we'll move on to our first session now, and I would take the opportunity to invite our eminent chairpersons into the gathering. It's really heartening to see that we are already 238 members we have joined in here. Thank you so much, everyone, for this beautiful response. And Nilima, can we have the chairpersons of the first session, please?
We have over 280 registrations at last count, and I think if you look at the figures at the end of the program, it will cross 300. So
I'm so glad,
congratulations to
sir.
all.
Thank you, sir. Thank you so much for everyone's response. So, to chair the first session, we have none other than Dr. Uday Thanawala. He is our past chairperson of the ICOG, a very eminent obstetrician and gynecologist from Navi Mumbai, and has been the vice president of FOGSI in 2015. He is the treasurer of the PCOS Society and has been the past chair of the Medical Disorders in Pregnancy Committee of FOGSI, the founder, secretary, and past president of the Navi Mumbai OBG Society, and a joint secretary in FOGSI in 2005. Sir has a very eminent academic career, and we've all benefited from his experience when he was the chair of ICOG. Thank you very much, sir, for chairing this session today. The other chairperson we have is Dr. Ritu Khanna, who's the director of the Khanna Medical Center and Fertility Clinic and fertility specialist and endoscopic surgeon from Varanasi, currently a member of the ICOG Governing Council, and she's been one of the past chairpersons of the FOGSI Food and Drug and Medico-Surgical Equipment Committee, and has held several eminent positions in the organizations and received multiple awards and publications, as you can see here. Welcome, Dr. Ritu. It's great to have you here. We also have with us Professor Arup Kumar Maji, a very astute academician who's the immediate past president of ISOPAB and presently a professor in the Shantiniketan Medical College, Bolpur, West Bengal. Sir really writes beautiful chapters, and his book has been one of the most popular textbooks in obs and gynae. And currently, he's also one of our governing council members. Thank you very much, sir, for joining in as the chairperson. I will now hand over the session to the chairpersons.
Thank you so much, Chinmay, for having me here as one of the chairpersons for this excellent session. And of course, greetings to Sheila and Prateek and everybody and Madam who's here. So when you talk of placenta, and Chitra will agree with me, and I and Chitra go back very long way, I think 20 years or so. 20 years back, when you see the placenta on the ultrasound, people used to say, oh, it used to grade it, like, oh, lot of cotyledon seen, lot of hyperechoic things seen in the placenta, and used to say, oh, this is becoming hypermature, deliver the baby. From there, the whole concept has changed, as in the third trimester, not to look so much at the placenta, but to concentrate more on the umbilical artery Doppler and the uterine artery Doppler and stuff like that. So our understanding is changing of how to view the placenta. Let me tell you one more clinical point. When you have a placenta, many people are told at 10 weeks gestation or at 12 weeks scan, oh, your placenta is low-lying. And that poor girl is told not to travel at all. Be careful. Take bed rest. Which I feel, the small uterus, which is 10 to 12 weeks, obviously the placenta will be coming lower. So sometimes it is very important to understand what you are seeing on the ultrasound, and that is why this particular session is so important, that we are focusing on the placenta, how to deal with a patient with different ultrasound reports and placenta, and that will be the full endeavor of this beautifully curated CME or a masterclass which Chinmay has done. And for the first speaker, I'll ask Chitra Ganesh to please come in. She's a fetal medicine consultant at Karthik Ultrasound Scan Center, head of the Department of Perinatology at Kaveri Hospital, Bangalore. She's, of course, interest has been high risk obstetric ultrasound and fetal interventions. She's a very good trainer, very good teacher, and excellent understanding. She's held various posts as secretary and president of the Indian Society of Clinical Sonologists, etc. So over to Chitra, and her topic is basically the placental morphology on ultrasound. So Chitra, you can start your presentation, and after that we have two very interesting talks in this particular session, and so stay glued on and we'll go on to it.
Yes, Dr. Uday, thank you so much. And Dr. Sheila Madam, I've been a FOGSI life member for the past almost 20-25 years, I think. My association with Dr. Hema Divakar, Dr. Uday, as he said, dates back very long time ago. And we are into obstetrics, and I also sincerely thank the FOGSI and the ICOG, and of course Chinmay and her team of Dr. Sita and Dr. Upma Saxena, who has given us the opportunity to have this placenta as an important topic. Shall I start sharing my screen?
Yes, please.
Yes. Placenta, as we all know, is an important feto-maternal organ with important functions throughout pregnancy. And the word placenta is derived from the Greek word plakos, which means a flat cake. That's how a placenta looks when you expel it out in toto with the membrane and the umbilical cord. Ultrasound, as we all know, is the primary imaging modality of the placenta, though we resort to MRI in certain conditions where we need to solve the problems with respect to better tissue characterization.
So in the next 15 minutes, we will go through the anatomy of the human placenta with common variations in ultrasound, because it is very important for us to say a normal as normal. And then that is when we start identifying or looking out for abnormalities. Very early in gestation, we know an intrauterine gestational sac is seen as a double decidual ring. The two chorionic rings, that is the double decidual ring, which is echogenic. Yolk sac is the one which is supplying nutrition to the fetus. There is no placenta at that time. So calling placenta at that early gestation is not correct. By about 8-9 weeks or 9 to 10 weeks of gestation, the area of future placentation gets identified as an echogenic or brightening of the chorionic rim. And we know this is the area where a future placenta is going to be formed. We still have the yolk sac in this condition. That means the nutrition is still through yolk sac. Placenta still has not taken over. There is an amnion seen. There is no fusion of amnion chorion for the placenta to take over. So again, the terminology of placenta should not be used at that early gestation. As Dr. Uday pointed out, sometimes we get reports with early pregnancy scans showing placenta low-lying, placenta in the anterior wall, posterior wall, etc. By 11 to 14 weeks, that is our NT scan stage, the fusion of amnion and chorion occurs in majority of the cases. The placenta is seen as an echogenic mass in either wall, anterior, posterior, or on the lateral walls of the uterus. The intravillous blood supply is identified, and you also see the retroplacental hypoechoic space. So placenta is visualized in ultrasound, and we can comment on placenta from about 11 to 14 weeks onwards. In the mid-trimester, we all know placenta is an homogeneous mass, slightly more echogenic than the surrounding myometrium. Has three parts. The central part, which is the parenchyma of the placenta or the placental substance. Then the basal plate, which is an echogenic side on the maternal side. And then the chorionic plate, which is on the fetal side. The retroplacental space has the decidua, the uterine vessels, and the myometrium. If you switch on color, you see the color flow of the uterine vessels in the retroplacental space. In B mode, it looks like hypoechoic. And once you switch on color, you get the vascularity. So this space is very important as you go on in the later part of the pregnancy. Cord insertion, yes, can be identified in the placenta. Majority of them are centrally placed cord. And when you examine the placenta, it is important, apart from the three layers of placenta, we do comment on the cord insertion site also. In the third trimester, placenta becomes much more heterogeneous with calcification seen everywhere. It can be within the placental parenchyma as specks of calcification. It can be calcifications in the myometrial junction or in the basal plate, or sometimes within the cotyledons also. These are all part of the normal maturation process. We do not give any much significance to the placental calcifications now. Having understood how a normal placenta looks, it is important that we know the variations which can exist in the placental morphology. First is the succensurate lobe. We call a placenta as a succensurate placenta when there is an accessory lobe which is much smaller, separate from the main placental disc, and it is connected by the blood vessels. The incidence is about 3 to 6%, much commoner in twins and in IVF pregnancies as compared to singleton pregnancy. The cord insertion in case of a succensurate placenta is always in the main lobe with the submembranous vessels connecting the two lobes. When the two lobes of the placenta, the succensurate lobe is seen on the opposite wall of the uterus, these unsupported blood vessels can sometimes cross or run over the internal os, giving rise to the condition of vasa previa and its associated complications. If the information about the succensurate lobe is not given in the antenatal scan, many a times it is missed when the baby is delivered. The main placenta comes out and suddenly the patient comes up with serious postpartum hemorrhage due to the retention of the accessory lobes. Patients with succensurate lobe, majority of them can be asymptomatic. Sometimes they can present with repeated episodes of bleeding, which is because of the hemorrhage occurring from the vessels which connect those two lobes. Next is the extracorporeal presentation. in a normal placenta, the chorionic plate extends till the periphery of the placenta and has a diameter which is similar to that of the basal plate. So chorionic plate and the basal plate are equal in size. But as in extracorporeal presentation, what happens? The chorionic plate fails to extend till the periphery, and therefore the chorionic plate is smaller than the basal plate, giving rise to the circummarginate or a circumvallate placenta. In a circummarginate placenta, you have the old blood vessels and the fibrin deposition between the chorion amnion membrane and the placenta. This is little difficult to identify in ultrasound as against a circumvallate placenta, where you see the fold of the amnion and chorion appearing as an echogenic line on the edge of the placenta. This is a very important sign of an circumvallate placenta. We need to identify this because the differential diagnosis of such an existence in the amniotic cavity is an amniotic sheet or an uterine synecdoche, which also presents as an echogenic line in the amniotic fluid, but here the extension is into the uterine wall. The incidence of circumvallate placenta is about 1 to 2%. Generally, they are asymptomatic. Complete circumvallate placenta, however, has a relative risk of placental abruption and hemorrhage. Because of reduced nutrition, the fetus can also be small for gestational age, requiring neonatal intensive care, and also chronic lung disease because of hypoxia. Coming to the thickness of placenta, the placental thickness increases with the gestational age, and the thickness in millimeter of the placenta is approximately equal to the gestational age. That's how you generally eyeball the placenta. We don't keep measuring the placenta in each scans we do. But whenever we find a placenta is thicker or thinner, then we measure and find out whether thickness is appropriate for the gestational age. It is usually measured at the center of the placental mass, perpendicular to the uterine wall, from the basal plate to the chorionic plate without involving or including the retroplacental space. The anterior placenta is normally little thinner or about 7 to 8 millimeter thinner than that of a placenta which is located posterior or in the fundal area. We call a placenta thickened placenta when in the mid-trimester an anterior placenta has a thickness of more than 3.3 centimeters or a posterior placenta which is more than 4 centimeters, and in the third trimester a thickness of about 6 centimeters and above is referred to as a thickened placenta. Placenta can be thickened in conditions like maternal diabetes, severe maternal anemia, torch infections, eye drops, etc. However, as a variation, whenever the placenta is implanted in a small area within the uterus, the small area of implanted placenta can mimic a thick placenta because the thickness is, the whole entire placental volume is getting adjusted to that small area of implantation. So this is a normal variation and should not be panicked or it should not be reported as a thickened placenta. Thin placenta, whenever there is a placental insufficiency like preeclampsia and FGR, the placenta can appear thin in ultrasound. However, a normal placenta itself can appear thin because of gross polyhydramnias where the increased liquor can push the placenta to the walls, making it appear normal placenta as a thin appearing placenta. Coming to the insertions of the umbilical cord, as I told you earlier, the umbilical cord is normally inserted at the center of the placental substance with the vessels going along the chorionic plate. Whenever the cord is inserted in the periphery within 2 centimeters of the placental edge, it is referred to as marginal insertion, generally not associated with adverse outcomes. But if it is very short distance, when the insertion is in a very short distance, about less than 5 millimeters from the edge, it may progress to a velamentous insertion of the cord. By velamentous insertion, we mean the cord is attached to the fetal membranes and not into the placental substance. The velamentous insertion in CSC is a rare condition seen in about 0.5 to 1.5% of singleton pregnancy, much higher in twin pregnancies. Here, the umbilical arteries and the veins are unsupported by the placental tissue and therefore they are associated with increased adverse risk for both fetus as well as the mother because of bleeding. They can cause fetal growth restriction, intrapartum fetal heart rate decelerations and changes, low Apgar, etc. And sometimes even perinatal loss. Coming to placental lucencies, the intraplacental anechoic heterogeneous areas which are less than 7 millimeters or greater is referred to as a placental translucencies or lucencies of the placenta. The most common is the placental lakes, which are seen as homogeneous anechoic avascular spaces in the placenta, which are surrounded by the normal placental parenchyma. This is seen in many cases, more than 18 to 20% of uncomplicated pregnancies. They are of little or no significance. But however, they need to be identified. Even when you switch on the color in the inside these lakes, they have low venous flow. So you can only see sometimes a swirling action and sometimes minimal venous flow within the lakes. However, this has to be differentiated from placental infarct, which appears also like an anechoic or an hypoechoic space with an hyperechoic halo around the brim. This is because of the fibrin deposition seen in the periphery, and it is seen in 25% of normal pregnancies, and the smaller ones are of no significance at all. But however, if the infarcts are larger, occupying greater areas in the placenta, then they are associated with the placental insufficiency, and this is seen when there is a maternal hypertension, preeclampsia, etc. These lakes have to be differentiated from certain pathological conditions like placental mesenchymal dysplasia. Here also the placenta is enlarged, multiple cystic areas are seen, but when you switch on color, it does not pick up color as against your placenta accreta spectrum, which picks up an enormous color within the lacunae or the lakes, which is seen within the placenta. We have an entire talk on placenta accreta spectrum following. Subchorionic hematoma is another common thing which is reported in our scans from the early pregnancy scans to the early first trimester, which is because of the rupture of the uteroplacental veins near the placental margins, which extends between the chorionic membrane and the placental space substance. Depending upon the time of the hemorrhage, the appearance in ultrasound also changes from hypoechoic to much more organized or an echogenic mass sometimes. Subchorionic fibrin or stasis of villous blood, which is seen beneath the chorion, that is from the fetal side. There is absolutely no vascularity inside, but if you have a large subchorionic fibrin, sometimes they may cause a jelly-like, if you just jiggle the patient or jiggle the placenta with your probe, you can see this jelly-like placenta, which is because of a large subchorionic fibrin. Though they are generally asymptomatic, these can be associated with IUGR because of less normal placenta being available for oxygenation. So to conclude, systematic placental evaluation is an integral part of our routine prenatal examination. Variations can be incidental, but are also associated with obstetric risk, and therefore it is important to recognize placenta, the normalcy of the placenta. If you find anything little abnormal or different from normal, need to be reported in the scan so that it could be followed up. And therefore placenta, reporting of placenta is an integral part of your obstetric scan report. Thank you so much for all of you.
Thank you, Dr. Chitra. I'll request the chairpersons to comment on this and move on to the next speaker, please.
Yeah. So, a fantastic presentation actually. But so many ultrasound photography I have not seen so in my long in such age, so much ultrasonography, the different variation, particularly has highlighted the placenta lucencies. There are so many lucencies, Dr. Chitra, your collection
Yes.
of the photography and also the ultrasound. I think all of you are your original picture, I think.
Yes, sir.
Fantastic collection. So
Thank you, sir. Thank you.
Yeah, and the beautiful images, I think. Beautiful images. Heartiest congratulations, Sheila, Madam, Prateek, sir. Fantastic, master classes going on. And thank you, Chinmaya, Sita, and Upma for inviting me here and making me a part and such beautifully curated program. So with this, it's a pleasure for me to invite the next speaker, a very, very dynamic and versatile Dr. Charmila Ayavu, who is the Director, Aditi Hospital and Pati Ayavu Fertility Clinic, Trichy. AP Dhanalakshmi Srinivasan Medical College, Perambalur. She has also been the Vice President FOGSI 2024, Secretary Justices Indian Association, the National Coordinator for FOGSI UNICEF PCA, and the series convener ICOG certification courses and the Journal Club 21 to 25, and chairperson for the Clinical Research Committee, FOGSI 2618 at 2016 to 18, and lots of awards and credits to her. So over to you, Dr. Chamila, for the early pregnancy bleeding and the rational use of placental supporting medications in the present day of obstetrics.
Thank you so much, Dr. Ritu, for that very, very kind introduction. Respected chairpersons, Dr. Uday Tanawala sir and Dr. Arup sir and Dr. Ritu. This talk is going to be on early pregnancy bleeding and the rational use of placenta supporting drugs. So early pregnancy bleeding is a very common but a clinically important symptom. The management depends on the cause, the severity, and the viability of the pregnancy. And when you want to identify the causes of early pregnancy bleeding, which is traditionally below 12 weeks gestation, the most common cause is a threatened miscarriage. It can be a subchorionic hematoma, and always we need to rule out an ectopic pregnancy when you have an early pregnancy bleeding. A missed or an incomplete miscarriage can present as early pregnancy bleeding, and rarely local causes like cervical erosions, polyps, and infections can cause a mother to bleed in the early pregnancy. How do you manage when you have a mother with early pregnancy bleeding? You should always assess the hemodynamic stability, do a transvaginal ultrasound to confirm that it's an intrauterine pregnancy, have to check for the viability. Lab investigations, a hemoglobin, a blood grouping, and an RH typing is needed. And suppose you have a doubt regarding the location of the pregnancy or whether you need to know the viability, you can probably follow up with serial beta HCG levels. And what are the medications which are placenta supporting for such a condition? And it can be used usually only in a threatened miscarriage with viable pregnancy. The other cause of early pregnancy bleeding may not respond to drugs which support the placenta. But the drugs which are traditionally used as a placenta supporting medications for mothers with threatened miscarriage with a viable pregnancy is progesterone, which is the most important. And the second drug which is used is human chorionic gonadotropin. The other drugs which have been tried has got a very selective use is tranexamic acid. It can reduce the bleeding in an early pregnancy loss because it's an antifibrinolytic. But the evidence is very limited in early pregnancy and is usually used only for postpartum hemorrhage, as in the women trial. And sometimes it has been tried in the use of significant bleeding, but it is not a standard recommended treatment for routine threatened miscarriages. Hematinics will form an indirect support to the placenta because iron and folic acid, when it's given, can maintain the hemoglobin levels of the mother. And it's very important in India because of our high anemia prevalence. And it will also support the maternal oxygen delivery, and that may indirectly support the placenta. The drug which is very commonly used for a mother who's got an early pregnancy bleed and it's a placenta supporting medication is progesterone, which is needed for creating a suitable endometrial lining for embryo implantation and growth. And it's a very essential hormone which is needed for the maintenance of a pregnancy. And when we want to talk about the physiology of how this hormone works, once ovulation happens, endogenous progesterone is produced by the corpus luteum. And suppose there's no fertilization, the ovarian progesterone production will fall, which will trigger an endometrial shedding and menstruation. But suppose the ovum is fertilized and it implants into the endometrium, the corpus luteum in the ovary will continue to secrete the progesterone, and that will prevent endometrial shedding, thereby protecting the fetus. Later in pregnancy, there's a switchover from the corpus luteum to the progesterone, for progesterone, where the placenta takes over the progesterone production, and this switch is regulated by human chorionic gonadotropin. It is a hormone which is for pregnancy. That's why it's named as progestation. And it works not only as a hormonal agent, it is also regulates the cellular immunity. And it's known to mediate the uterine blood flow, mediate the uterine endothelial adaptation to pregnancy by an increased nitric oxide production. And we know that when there's a drop in progesterone, it is one step that facilitates onset of labor or a bleeding, as in an early pregnancy bleeding. Progestogens which are used as a drug are classified as natural or synthetic. Natural progesterone is the one which has got chemical structures that are like those produced by the body and is available as a micronized vaginal gel or pessary. Synthetic progestogens or progestins do not correlate with natural progesterone and are artificially manufactured in a laboratory. The examples of progestogens which are synthetic are the injectable 17-alpha hydroxyprogesterone caprolate and oral dydrogesterone. Natural progesterone is known to suppress the myometrial contractility, but a synthetic progestogen like 17-OHPC may not have this effect, and it actually may stimulate a myometrial contractility if it is given in higher doses. Although intramuscular progestogens are known to bypass first-pass metabolism in the intestines and liver and achieve a very high circulating progesterone level, the level is maintained also for a longer duration when compared to a vaginally administered progesterone. But there's no clear evidence to show that when you give an IM progesterone is much better compared to a locally used progesterone like a vaginal administered preparation. But there are no trials which has reported a long-term follow-up of progesterone treatment in recurrent miscarriage. And that's why the long-term safety of progesterone supplementation is still not well known. But at this point of time, there's no evidence to show that progesterone can cause an anatomical or physiological abnormalities in fetus. And that's why it's continuing being used in the first trimester of pregnancy. And how does progesterone work? It acts by immunomodulation. The paradigm between TH1 to TH2 is the way it helps in maintenance of a pregnancy. So progesterone can inhibit the production of TH1 cytokines and will upregulate the production of TH2 cytokines. So when you have more of TH2 cytokines upregulation, you will have a normally progressing pregnancy. But if TH1 becomes higher, it can lead to a miscarriage or abortion. And progesterone is also known to stimulate the production of progesterone-induced blocking factor, which will induce more of a TH2 response and a downregulation of natural killer cell activity, and thereby it will exert an anti-abortive effect. So it can act directly, it can also act indirectly through progesterone-induced blocking factor in continuation of a pregnancy. And for that, you need TH2 to be higher in the body. And what is the indication for progesterone in obstetrics? It can be used in threatened miscarriage, as I said earlier, can be tried in recurrent pregnancy loss, is useful for the treatment of short cervix and also in the prevention of preterm birth. In recurrent pregnancy loss, the pivotal role is actually by the progesterone receptor-mediated immunomodulation. So when you have a implantation factor which will produce more of progesterone-induced blocking factor at the decidual and the PBMC level, the progesterone level will be sufficient enough to continue the pregnancy by forming the asymmetric antibodies of TH2 with a bias towards NK cells, and that will protect the fetus and it will go on to a full-time delivery. But when there's a progesterone level which is insufficient, it can form lesser of progesterone-induced blocking factor. So there will be a bias towards TH1, and that will increase the cytotoxic inflammatory abortogenic reaction, and the pregnancy can go for an abortion. And progesterone, as said earlier, will play a role in preserving an ongoing pregnancy, but it has to be a non-genetic threatened abortion. And the mode of action can also be through an extra-endometrial immunological protective effect, and it will also have a myorelaxant action on the uterine myometrium, and that may play a role in the management of threatened miscarriage. And that's why it's been recommended for treatment in patients with threatened abortion. And there was an analysis which was done by Dr. Kumarasamy et al. In 2020, and they said the benefit of progesterone may be small, but it has got a very positive treatment effect, and that is dependent on the number of pregnancy losses. So when you have a dual risk factor of an early pregnancy bleeding, and also the mother has already lost one or more previous pregnancies, these high-risk women, when given progesterone, will have benefit. So what are the dosages which has been advocated? Because there are so many different doses being used by different guidelines. But in 2022, this study by Chester et al., which includes Jayaprakash and K, have said, suppose a mother has come with vaginal bleeding and already she has lost one or two previous pregnancies, start at a dose of 400 milligram twice daily at the time of presentation of vaginal bleeding and continue till 16 completed weeks of pregnancy. But she is asymptomatic, does not have any vaginal bleeding, but has come with a history of 3 or more previous losses. Prophylactically started on 200 milligram twice daily and continue until 12 completed weeks of pregnancy. And suppose she is asymptomatic, but after that she starts spotting or bleeding after you started progesterone, and the bleeding episode at that time, you can increase the dose to 400 milligram twice daily and continue until 16 completed weeks of pregnancy. According to Estre, they said it's better that in a patient who's got a previous pregnancy loss, to prevent a bleeding in this pregnancy, you can actually start progesterone from the luteal phase rather than after a positive pregnancy test, which may actually help in maintenance of pregnancies. And according to ESHRE, vaginal progesterone should be used to improve the live birth rate in women who have lost 3 or more pregnancies and have got a vaginal blood loss in this pregnancy. And American College 2023 has said progesterone can be used for the prevention of preterm delivery. And that is for women who already have a history of a preterm birth in a previous pregnancy and now has got a singleton pregnancy with short cervix. And the drug you will use and the route you will use is vaginal progesterone. Intramuscular 17-hydroxyprogesterone caprolate is not advised by American College for the prevention of recurrent preterm birth. It is not accepted as it was not found to be of any use. It is not because of any teratogenic effect. The FDA based its decision to stop the recommendation only because they found that the drug was not useful at all for the prevention of recurrent preterm birth and not due to any safety concerns. The next the next hormone which is useful for early pregnancy maintenance when there's a bleeding episode is human chorionic gonadotropin, which is a glycoprotein hormone. It's produced by the syncytial trophoblast and it is detected almost 6 to 8 weeks after fertilization happens. It is integral to early fetal development through its role in implantation and for the establishment of maternal fetal circulation. It has got a very wide use in reproductive medicine, but its role in obstetrics is limited and highly specific. And it's involved in the preparation of the uterine wall in a normal pregnancy for the implantation and also for the maintenance of the corpus luteum. Will help in angiogenesis and vascular remodeling. Will be useful for immunomodulation to facilitate invasion of the uterine wall without the fetus being rejected by the maternal immune system. And will also help in the growth of the uterine muscle and the volume in accordance with fetal growth. In a large study, they said in the first trimester, suppose there's a low HCG level, it will be associated with an intrauterine fetal death. And when the mother has got a high HCG level, it's associated with the development of preeclampsia later on. But suppose the second trimester HCG level is high, it is associated with IUFD and preeclampsia. And there's no pregnancy outcome reported when there's a low HCG. So there's no actually evidence on a low HCG having any causing any problems in second trimester. So what are the indications for HCG? For luteal phase support, it is one of the most important drugs. It is important in early pregnancy until the placental takeover happens for the secretion of progesterone. That is at 8 to 10 weeks. And the dose you will give is 1,500 to 2,000 international units IM every third day until 8 to 10 weeks. In recurrent pregnancy loss, it is supposed to promote Treg cells, reduce the NK cell activity, and enhancement of trophoblast invasion. But the evidence of use of HCG remains inconsistent for this indication, and there's no guideline-based standard therapy. For fetal growth and placental function, there's supposed to be a proposed role in enhancing angiogenesis and preventing early placental insufficiency, but it's also not the standard of care and it's not advised as a guideline-based standard therapy. It can be used for threatened miscarriage at a dose of 1,500 international units IM twice weekly for at least 2 to 3 weeks, but here also the evidence is weak and only a selective use can be advised. And according to the guidelines, NICE guidelines for 2021, preferred progesterone over HCG for a mother who has got threatened miscarriage. According to American College, there's no routine recommendation for HCG in miscarriage prevention. RCOG says there's a limited evidence for HCG therapy in recurrent pregnancy loss. And these are my references. Thank you so much for a very patient hearing. Thank you, Dr. Chinmayi, for the opportunity. Thank you so much.
Thank you. Thank you, Dr. Chamila, for that really, precise, crystal clear presentation. And you beautifully highlighted, the specific drugs, the exact timings when you need to give, and the doses at the same time prognosticating the patient also. And I think though we do our best to treat, we still keep our fingers crossed till the fetus reaches maturity. So thank you so much.
Thank you,
I
Ritu.
think,
Thank you so much.
Charmila, well done. There are so many questions in the chat box. So,
I'll answer them.
Yeah,
Yes,
if you can answer them, no?
yes,
I saw some 3-4 questions.
Thank you so much, Dr. Ritu. Can I just
Why don't we
request
answer the
Arup
questions
sir
now?
to
Thank
introduce
you.
our next
Thank you, Dr.
speaker?
Charmula, for your excellent presentation covering all the things
thank you, sir.
and recent advances also.
Thank you.
Now the time Dr. Vandana Valsal, who will present the navigating low-lying placenta and the ultrasound of the placenta accreta spectra. And Dr. Vandana Valsal is the additional professor and our CG Vardhya Hospital, director, Surya Fetal Medicine in Mumbai, an obstetrician with super specialization in fetal medicine and intervention, is very well-known person. First postdoctoral fellow of the National Board in India, qualified in high-risk pregnancy and perinatalology. 28 years of experience in obstetrics and gynecology, including 23 years in fetal medicine. And he's a MUH approved faculty. So there is so many awards also to him. I am not going to detail, Dr. Vandana. I think you start your topics, the navigating low-lying placenta and the ultrasound of placenta activity spectrum is a very favorite topic. Before passing to that, I must congratulate all the organizer, particularly Dr. Chinmoy, Dr. Pratik, and Dr. Sita for selecting a topic in 8 topics on placenta. Actually, Madam has said, Dr. Sila Madam has been, it is the most respectable one, really. 8 topics on placenta is a today. I've never seen such a. And in the first batting was Chinmoy was in Goa, and this book, that is the book you publish with a quick, only few weeks, and very, very good write-up. Thank you for the same, Dr. Chinmoy. So, Dr. Vansal, you please
So before Dr. Vandana begins, we have Dr. Parag Biniwale, our past chairperson here with us. Thank you, Dr. Parag, for joining us.
Dr. Parag, are you there?
Yeah, he's there.
No, that's okay. Please carry on. I'm just here to listen to, because the title is so catchy and interesting. Earlier this morning, I messaged Chinmay that this is an innovative title, and I'm definitely looking forward to some interesting sessions today.
Placenta has attracted everybody.
Yeah, that is
there. But in between the placenta, if placenta betrays, we will not be here.
That's what I said. No, because of placenta, we are here.
Most respectful organ.
And that shows on the 500 participants which are there. Everybody is glued and nobody is going out of that. Placenta is so important, ma'am. Congratulations, Dr. Sheila, ma'am, for thinking of this topic and bringing up so many topics.
Thank you to all. Thank all of you.
Yes, ma'am. I'll share my screen.
I think before Vanda goes ahead, I think Charma is this one thing that Dydro.
Sir?
Uday wanted to say something. Yes, Uday. Uday, you have to unmute.
Unmute.
Yeah, so I was before, sorry, Vanda, before you go ahead, one point I want to clarify with Charmila is, she said dydrogesterone is not advised by guidelines for management of threatened miscarriage. Now, what I would understand, or what I was under the impression is that whenever a patient of mine complains of some threatened abortion, normally, even if I have to email or tell her over the phone, I said, okay, take 4 tablets of dydrogesterone, 10 milligrams stat, and then make it 1 BD as an immediate support for the pregnancy. And I think this is a very well accepted therapy in clinical practice. What are your views on this, Charmila or Vandana, or
So
even Chinmay can answer?
I went through so many times the guidelines, and Estre kept on changing his ideas every year. Like in 2022, they said oral dydrogesterone is good enough for threatened miscarriage as well as for recurrent pregnancy loss. But the recent guidelines, they've said very clearly, vaginal progesterone should be used for threatened miscarriage and recurrent pregnancy loss. They are not advocating oral progesterone now. So the next year it may change. But up to this time, they have changed from oral to vaginal. And that's a recent guideline.
So I really don't know, because patients will not be comfortable putting a vaginal preparation when they are bleeding. That is number one.
Yes.
Secondly, it is so easy to take oral dydrogesterone. Some of these guidelines are more because of the insurance covering up the therapy or whatever. If this is more expensive, they will not give it. But I think we've all got good results with using dydrogesterone.
In the dosages which I mentioned, the Jayaprakasan study, they have said very clearly, when you keep it deep into the fornix, it will not interfere. Whether when there's a bleeding, it is going to be heavy bleeding. She's not going to be helped with any drug. With those spotting and all that, even you keep vaginal progesterone, it will not change the absorption. That's what the study has said.
But I think, Charmila, there are studies on dydrogesterone also.
Yes, madam. Right? Yes, madam. But the recent guideline, that is in 2021, one guideline very clearly said use oral. Then they switched over to vaginal in 22. In 24, again, they changed back to, I think, oral. Now the recent is vaginal.
And the
Yeah,
dosages
but
are
I think
also
in
changing.
clinical
that
practice we have to have our
400.
But I think
so
we
This
should
is a
really
never-ending
look into it.
discussion.
As Dr. Uday Thanawala said, that we give her 4 tablets as soon as she has threatened abortion, right?
but it's not
And then,
guideline based standard therapy, madam, because
yeah,
guidelines are
okay,
not available.
good, you are explaining that, but it keeps
I
changing.
use oral dydrogesterone,
That's
but
what
I'm talking what the guidelines are saying.
I wanted to
So
put up that question to everybody, that how many of you are using dydrogesterone
I
in
use oral dydrogesterone. Anyway, I'm more comfortable with an oral drug. But the guideline,
exactly.
I went on and again, Uday sir, to just find out like how you can keep a vaginal drug when the patient is having a bleeding episode. But they
No,
have
no,
said
that
very
that
clearly, you keep it deep into the
yeah.
fornix and it will not interfere with the absorption when the patient is just spotting. That's what the study has said.
Since
No,
this
no.
is a
Theory-wise,
never-ending discussion,
theoretically, it is fine, but the only thing is, how is the patient feeling doing that? That is number one. But I think that we are all comfortable with oral dydrogesterone or oral progesterone. Of course, oral micronized progesterone doesn't act as well as vaginal. Agreed. Oral dydrogesterone can substitute because we in IVF also are using it rampantly, and we are, using it rampantly in threatened abortion. So clinically, we still use it. So let's go ahead with that to the next topic of one last topic. Thank you very much.
Thank you, sir.
Thank you so much. So I go on to our next lecture, and it is going to be a very simplified lecture because placenta previa is something that we all need to know, and ultrasound will work as a GPS to find out how do we look at the placenta. So yes. So we know we use placenta previa, the term when we have an abnormally placed placenta, either it is overlying the internal os or it is close to the internal os. So if you look at the incidence at the time of delivery is very less, around 0.5, but it is much higher at our anomaly scan. We get so many reports of placenta low lying, and so it is 3 to 6%. But about 90% of these will either migrate up just prior to delivery. That is why there are guidelines for placenta previa also, when to scan, how to diagnose, and also how to manage it. So with that background, we will first look at the risk factors. We know placenta previa is very common now because we have more cesarean sections and also more terminations being done, curettage, any uterine surgery, there's higher chance of placenta previa. Any scarring on the uterus will cause like even a manual removal of placenta. Then our advanced maternal age, smoking, cocaine are also responsible. And if the placenta is big, like in a multiple pregnancy or in an ART where it may be thin and big, we will have problems of placenta previa. And yes, if there is a placenta which is low lying previously, we can still have a similar thing. So why are we so worried about this? Yes, we have a higher chance of antepartum hemorrhage and also a life-threatening postpartum bleeding which can happen. More transfusions might be required, so we should be ready with blood whenever we have a placenta previa. There might be requirement of hysterectomy, especially when associated with accreta. This placental bed is in the lower part, so the sepsis also, subinvolution is also more. And yes, as we said, that there could be a life-threatening maternal death also. Additionally, when we have placenta previa, we are also expecting that there will be spottings and bleedings, and we might end up in premature birth for the babies as well. So this is a very old classification which we used to use when we used to do a double setup, do a PV examination, feel the placenta, and then this classification was given, which was grade 1 when we were able to touch the placenta but still not on the internal os. Then one which reaches the internal os, marginal when it is partially covering while it is undilated, and complete placenta previa. Actually, this has to go into the bunk, and it has been completely stopped for a long time. Now it has been replaced by ultrasound, and all our now diagnosis of placenta previa is only on ultrasound. So even in a time as 2016, we had this summary of the fetal imaging consensus where they had completely stopped these complete or total placenta previas and the marginal placenta previas completely abandoned. But we still, as our students in our medical colleges, are still using these terms. And from this, maybe we should stop using these terms. And the only terms that are available now are either it is normal placenta when the placental edges more than 2 centimeter from the os on ultrasound. Or if it is less than 2 centimeter from the cervix, we will call it as low lying. And if it is covering the cervix, it is placenta previa. So it is only normal, low lying, or it is placenta previa. There is no other terminologies to be used, and this is the definition based on our ultrasound findings. So here you can see there is a bladder which is partially filled up and good for a placenta to be seen. And this can only be diagnosed mostly after 16 weeks if the placental edge is more than 12 centimeters. So only we give a definition of placenta previa after 16 weeks of gestation. Here it is more than 2 centimeters, so I will call it as normal placenta. Here, if you see, the placental edge is less than 2 centimeter from the internal os, and so I will call it as a placenta low lying. And the first image is a transabdominal image, so I'm not very sure of the place of the edge of the placenta as well as the edge of the internal os. And in the second one, it is transvaginal, which is the best method to look at, where I can very well define the edges as well as the internal os. So if it is less than 2 centimeter, I will call it low lying. And if it is low lying, I will follow it up at 32 weeks. And maybe if it still remains, I will see her again at 36 weeks with a transvaginal ultrasound. So this is important. And here, if you see, the placenta is completely covering the internal os. It may partially cover or it is completely covered, will be all called as placenta previa and nothing else. So now we want to also understand this diagnosis can only be made after 16 weeks. So can in the first trimester during my NT scan, can I call it placenta previa or low-lying placenta? The guidelines say that it should not be reported, as it may over-report the placentas and the patient may get very worried. But clinically, if you ask me, if I see a placenta low and the patient is spotting and bleeding, I have an answer for why it happened. Maybe I will not scare the patient for a placenta previa if she's not bleeding, but if she's spotting and the placenta I see on the lower side, I might be more worried and maybe start her on progesterones and rest, but not otherwise. So now how do we diagnose and what is the screening test? So our screening has to be during our anomaly scan. So every anomaly scan, when we are looking at the fetus, we also look at the placenta, and this is usually done transabdominally. But yes, if the bladder is not full, you might falsely call it positive or even negative. If there are BMIs more or there is scarring or contractures, we might overdiagnose or underdiagnose. That is why transabdominal ultrasound is not so good. If I suspect there is placenta previa or low lying, it is best to do a transvaginal ultrasound. And the safety of this transvaginal imaging has been well established even if there is active bleeding. So your transvaginal probe doesn't increase the bleeding, and you could do a good transvaginal ultrasound. It doesn't touch the cervix and it doesn't cause extra bleeding, but the edge of the placenta can be very well defined, and so TVS is the preferable method with a positive predictive value of almost 93% and a negative of 98%. So that means we are very sure on a transvaginal that it is placenta previa and not otherwise. So now as a obstetrician, I also want to understand, if I see a placenta previa at my anomaly scan, how many of them will migrate up? So there is a good study which says if it is more than 2 centimeter covering the os, none of them will get migrated. So that means if it is a central placenta previa, it will always remain. But if it is more than 2 centimeter from the os, that means it is already away, and so we 100% it is going to be more than 2 centimeter. And if it is less than 2, that means low lying, 90% of them will go up, except if there is a scarring of the uterus, where there might be a difference of what these statistics are giving us. So if it is central placenta previa, we need to tell the patient this may not change, and if it is low lying, 89% might change, and if it is normal, it is normal for practical purposes. So now if I have an ultrasound which shows placenta previa at anomaly scan, my next scan can be for our growth at whatever time, but for placenta, I will see her again at 32 weeks of gestation if it is asymptomatic. But if it is symptomatic, recurrent bleeding, or I suspect an eccrita, then I might do it earlier so that we can plan our decision for when to deliver these patients. And if at 32 weeks again the placenta is low, then in asymptomatic patient, I will recall them at 36 weeks to plan the time of delivery and the method of delivery. So while we have a low-lying placenta, is it important to look at the cervix length? So if the cervix length is long, that is more than 3 centimeter, the chances of preterm emergency deliveries and bleeding and massive hemorrhage is less. So it is just a good reassurance that if the cervix is good, she may not have a preterm delivery. And if it is short, then you be worried that she might suddenly come with a massive hemorrhage. There's no role of cerclage for just reducing the risk of preterm or bleeding in a case of placenta previa. So now management. So most guidelines say that if it is less than 2 centimeter from internal loss, then this is an accepted threshold for deciding for cesarean section. That means if it is less than 2 means it is low-lying or placenta previa. That anterior and posterior and dangerous placenta previas have all been now gone out of terminologies, and only if it is asymptomatic placenta previa, we give a steroid between 34 to 36 weeks. This is by Indian guidelines, FOGSI plus the RCOG guideline and by the Barcelona. And we repeat a scan at 36 weeks and deliver between 36 to 37. For Indian context, we would think if asymptomatic, 37 to 38 is a better time. And the Barcelona also says the same thing. But if there is a placenta which is low-lying or previa and bleeding, then we give the steroid as per whenever the bleeding happens. And if it remains stable, then we would deliver between 34 to 36 weeks. Again, for Indian context, I would think it would be better if the bleeding is not very high to deliver at around 37 weeks of gestation. Asymptomatic low-lying, that means within 2 centimeter, some studies say that you can actually opt for a vaginal delivery with a success rate of 70%. But that is more individualized. Every obstetrician can decide what to do for them. So now for these patients who have a placenta previa, if I'm deciding to do a cesarean section, on the table, looking at the placenta is very important because where you will give the incision will be important. So if your placenta is low and going up from posterior to anterior, you might want to give a little higher incision so that the placental edge is thin. But if it is coming from up downward, I will give a slightly lower incision so that the placental edge is as thin as possible. And if you cut through the placenta, you need to deliver them fast, that we all know about. So in addition, when we are looking at placenta previa, I also want to look for the cord because these previas may be having a velamentous cord insertion and which may be crossing over the cervical os and causing vasa previa. So it is very important when you see placenta previa, look for vasa previa. Like in this case, you have a low placenta. There's a cord which is going through the membrane over the cervix into the other side. So if I do an ARM or she bleeds, she will have a problem and exsanguination. So it is important for all these that you look at the cord for vasa previa. And this vasa previa also you put on color whenever there is placenta previa, when you look at the edge, because there could be a cord which is seen and where you will have to do an elective cesarean section before the labor starts. Again, you may also have this vasa previa and a placenta previa with a succensurate lobe. So you have a separate placenta and one placenta on one side. And again, this may be associated with velamentous insertion as well as more chances of IUGR, PPH and subinvolution. So this is also placenta previa, but it is the succensurate lobe which has become placenta previa. This was a twin pregnancy in which one of them had a central cord and other was velamentous. And this velamentous cord and the placenta was low lying. And so again, it is important when you have twins, usually one of them, especially in MCDA, will have a velamentous cord insertion and you will need to look for it. So Chinmay told me to take some amount of PAS. So placenta accreta spectrum, the management will be covered later on. But just for the diagnosis on ultrasound, when it doesn't separate at the time of delivery, we will call it as placenta accreta spectrum. It is very important to diagnose it antenatally and deliver in a tertiary care center where everything is available. So this is the only one method by which we can reduce the mortality for these cases. So we all know accreta, increta, and percreta is there, and all of them, the risk is very high with the number of cesarean sections that are done. And if there is previa plus cesarean section, very high chance of accreta. So your eyes have to start looking for accreta. Any surgeries, any uterine anomalies, ablations, Asherman syndrome, all of them, your eyes should look for accreta when you are thinking of placenta previa with a previous scar. And this was a big editorial on the descriptors. So I have just 5 slides to show you what are the descriptors for placenta accreta. So a normal placenta is seen where the margin is seen well. 5 minutes. And there is a very good clear zone which is seen. And in the second one, there is no clear zone at all. And so this is loss of this hypoechoic plane that we are seeing. Second is a bladder wall interruption. So the first one is normal where the bladder wall is seen vertical. And the other one, we see this placental wall interruption that we are seeing. Third is looking at the thinning of this myometrium. Here the myometrium is seen well. Here the myometrium is completely thinned out. It is less than 1 millimeter in size. And then you see this bulge. If you see this kind of a placental bulge into the bladder, it is significant for placenta accreta. And look at this exophytic mass that you are seeing in the placenta accreta spectrum. Put on the color, look for this hypervascularity, presence of this vascularity, again suspect placenta accreta, and more vascularity is in the subplacental area, and also they are bridging vessels. So bridging vessel means these vessels which are going into the placenta, again a very significant indication for abnormally placed placenta. And you'll see a lot of lacunae in the placental edge, and yes, 3D also will help. So one last, scar ectopic can also, if you continue, will become placenta accreta. Here there was a scar ectopic not managed, and so even at around this 12, 13 weeks also, there was placenta accreta which could be seen. So my last slide, do I do an MRI in all these cases of accreta? I would think our ultrasound has become so strong that we will be able to pick up most of the accreta. Yes, it helps us in defining the depth as well as the lateral extension, and if there is any bladder invasion. But most of the time, our ultrasound itself is as sensitive as what MRI is, about 94%, and specific also. So our eyes should be open for placenta accreta in placenta previa, especially if there is a scarred uterus. Thank you for a patient listening, and maybe I can take questions if you want. Uday sir, I think you are going to take up placenta accreta.
No.
No.
Thank you, Dr. Vandana. Thank you,
Do
Dr. Vandana.
ultrasound only, so.
You are really covered up the things. Very beautiful.
Fantastic.
So, Dr. Ritu, will you continue the discussion? Dr. Ritu,
Yeah,
please.
sure, sir. If you have more questions, can we take them?
Another webinar with me.
Yeah. And that was a fantastic deliberation, Vandana madam, as usual, and you really brought it out, where the section has to be done. And they're all practical points which we really take home today. And
I think the questions the faculty can just answer
yeah,
in the chat
because
box.
they'll
That
keep,
will be the
Usually
thing.
do them in the chat
We
box.
had
Dr. Suvarna
Suvarna
Kadilkar
ma'am.
has joined
I
us.
think, Charmila, you must give some amount of time for
So-
questions. You must have everybody's hear the questions. It'll take 2 or 3 minutes more because that is important. You must clarify the questions when the session gets over. If everybody answers in the chat box, they'll be busy there. They'll not listen to the second lecture. So how does progesterone help in bleeding due to when the placenta is low lying? How does it help to stop bleeding? Anybody will answer that? Jayashri Bedekar has asked that question. So I think here tranexamic acid will help more than the progesterone, but progesterone is basically given to keep the uterus quiet and to support a pregnancy, even when there's a low-lying placenta. Your question is right. That is where it is. And there was one question which I saw in twins, is the dose of progesterone different? No, it's not different. We give the same dose even if it's a twin pregnancy. I think these were two questions which were pending. Now you can go ahead with the next session.
So since Dr. Suvarna Madam has joined us, can we have her words of encouragement, please?
So I don't think Pratik ICOG needs any words of encouragement. They are already doing brilliant work. So congratulations to the whole team led by Dr. Bhaskar Pal as a president, Sheila Mani and Pratik, and Dr. Ashok Kumar as chairperson elect of ICOG, Dr. Sadhna Gupta, and of course all of us who are there. And today's convener is none other than a dynamic Chinmay Ratha, who is going to take all the. I like the the master class on placentology. If there are students who have logged in for this program, there is a full essay that comes in the on the the subject as a placenta, and you have to write for 3 hours. Completely on placenta. So it's a favorite essay of university exams, and I think you have covered almost everything. I'm just going through the entire program of the scientific sessions, and I see so many of experts in that. I think first of all, the convener, Dr. Chinmay, Dr. Sita and Upma, who are co-conveners. I just now saw Uday making, I can say a lot of important points on various questions on the chats that you received. I think apart from that, I heard even Vandana's lecture. Was also very good as usual. Charmila, I missed part of your lecture if you are already finished, but I'm sure it must have been good. And of course, Ritu and Arup Kumar Maji sir who are chairing this session. So I think overall there is a good collection of experts for this particular seminar. I see the attendance 533 people have logged in. So I must say the whole set is crowd puller, and all of you have managed to get more attendees because it's nothing else but the topics which are really very, very well, curated. The program is well curated, and all the speakers and the chairpersons who are really very much knowledgeable. So I once again congratulate all of you for this, and I see the next session will be of Chinmay, then Upma Saxena, then Prashant Acharya, Sita, and last will be, I think, Dr. Bela Bhatt. All of you are doing brilliant work in the same field. So I congratulate everyone once again and wish you all the best. Thank you. I have Dr. President-elect Dr. Madhuri Patel here. So I think she would also like to say a few words.
I think we are a little late, Pratik. For the same, I am really sorry. But we are sitting in the FOGSI office doing some work, and we say we have to log in. Such a lovely placentology, or topic on masterclass on placentology. It is very important because everything starts from the placenta. The baby, the weight of the baby, IUGR, placental insufficiency, so many things we diagnose. We have so many expert fetal medicine people, and I know everybody of them. They are doing very great work as far as the clinical part is concerned, and they are also doing the implementation of this clinical work. So I know, especially Chinmaya, Sita, Upma, Chitra, Charmila, Vandana, then again, we have a Prashant, Acharyas, and then Bela Bhatt. They are really good speakers, and they are clinicians. See what happens when you do fetal medicine, you just do the fetal medicine, okay, this diagnose this, aneuploid, this, that, some, and then, hand over the patient to the obstetrician. Well, these people, they really, what they diagnose, they, follow the patient and they deliver them, and therefore they know what is the outcome, what they had done during the antenatal period, fetal medicine part, and what now the results are. So we have all prognostic aspect on that. And I'm very happy that, all these fetal medicine people are doing excellently well. I must say, Chinmaya, we are planning very big thing during my presidential year. And, we are going to have one topic, CM is on placentology. And that will really help all our obstetrician 47,000 plus how to go about. So in future, we'll have a healthy, health generation. And that is more important to have a healthy generation, healthy family,
Thank you.
healthy
Thank you.
community,
Thank
and
you,
a healthy
Madhuri.
nation. Sheila,
Yeah,
I
thank
should
you,
see
Madhuri,
you on
for
my
joining.
so Sheila, excellent, master classes are going on. Sheila, sorry I could not see you. So it was nice of you. Nice of you to, see
It
you.
cannot happen without Sheila.
Yes, it cannot happen. It cannot happen. So Uday and everybody, Dr. Maji, Dr. Sheila, Pratik, congratulations to all of you.
Okay,
Yes.
fine.
Thank you.
Thank you. We will
Thank you so
proceed.
much for
Yeah,
coming
thank
in,
you.
ma'am.
Thank you.
We are already delayed. Can we have the introduction of the next set of chairpersons? Thank you to the chairpersons of the first session, of course, and three excellent speakers.
Thank you. Thank you, Dr. Pratik. And we move on to our next session, where we have another set of brilliant talks. And to invite the chairpersons, it's my honor and privilege. The first chairperson is none other than our past chairperson of ICOG. Can we have the slide, please? Introductory slide. Dr. Mandakini Meg, madam. She needs no introduction at all in this forum and in FOGSI and ICOG. She has been our ICOG chairperson in the crucial period of COVID, where she actually changed the face of ICOG, doing so many programs online and so many activities. And she has been, now she's the president of Association of Medical Women, international president of the Association of Medical Women. And she has been the international vice president, MWS Central Asia, multiple awards and honors to her credit. Welcome, madam, and it's really an honor to have you with us today. Dr. Mala Arora, she's not been able to join because she's not in the country right now. But may I ask Dr. Sheila Mani if she can
I am
join,
here.
please?
Yeah.
Yes, thank you, madam. And again, another vibrant, dynamic chairperson we have this year, Dr. Sheila Mani, who needs no other introduction. Thank you for this opportunity.
Thank you.
And I'll hand over the session to both of you. Thank you.
Yeah, so thank you very much, Sita. Am I audible?
Yes, ma'am, you are audible, visible.
Yeah.
Your logo is also visible.
It was a very standard question in our COVID days that Desi Tank used to say, am I audible? So, that is a wonderful question. First of all, I must thank you. You may prevent me from thanking, but I have to thank Sheila and whole team, Pratik, yourself, Chinmay, Sita, and whole the team of ICOG for taking this wonderful, subject. Everybody has expressed, but I will call it a script writing. When you have brilliant script writing, a brilliant subject, then it is a hit formula. And same is like, I will call it a Dhurandhar of this movie. You have really crossed so many registration and brilliance of your script writing, choosing the subject very correctly, and also having the faculty which is very, very expert. With these words, I think. And one more thing which Pratik has mentioned, that we have sown the seeds of the digital education in our time. Taking the challenges. When I become chairperson, he was there on the stage, Charmila was there, so Chinmay was there, so many people, and we thought we are going to blast and physically do so much. But immediately after my taking over as a chairperson, we faced this challenge of the COVID. And then we converted this challenge into the advantage. And I can see when whatever seeds of digital teaching I have sown as a chairperson has become full grown tree. And I must thank each and every chairperson who in the process, Parag, Sheila, Uday Thanawala, so many of them, they have really taken it forward, and I'm extremely thankful. And it is like homecoming. So I just express my, sentiments for the ICOG. It is my home. So with this, I think I'm going to introduce a very dynamic person. Chinmay, you are a very unique personality. I took your help while making my inaugural speech of ICOG. You are from Lucknow. You gave me a lot of shero shairi. But the other side is, of course, a great academician, educator, and also a great orator. So with this
Thank
one,
you, ma'am.
the stage is yours. Please go ahead with your topic.
Thank you very much, ma'am. I am really thankful to Sheila Mane ma'am and all the seniors of ICOG for supporting this endeavor of taking a masterclass on placenta. And all of you have spoken of clinical problems and the real insights into placenta, whereas I'm going to take you a little bit into the thought-provoking zone of novel uses of placental extract. Now, placentology is about studying various aspects of the placenta. And is there a potential life in the placenta? Because every time there is a baby born, there is also a placenta born. And this is the birth which Sheila ma'am was referring to as the lotus birth, where you don't actually remove the placenta and let the placenta come in there. We have already heard of delayed cord clamping, where you allow more of the placental cells to move into the fetal body and allow the baby more power to regenerate. So one thinks that is there life in the placenta after the birth of the baby? So there is this concept of human placental extract. So in pregnancy, we know the placenta itself is a unique organ. We've already revered that organ and said it's one of the most respectable organs, and how there is a fetal aspect to it, there's a maternal aspect to it, and it plays a unique role in nourishing the infant, so much so that we are classified as viviparous organisms only because of the presence of the placenta. But once the placenta is delivered, many of us throw it in the dustbin. But like Sheila ma'am was saying, in some cultures, it is preserved, it is maintained in some way. There are even some tribal cultures where they eat the placenta, and some places where they preserve it for posterity. But in scientific parlance, you know that this is the same organ which nourished pregnancy for 9 months. So it cannot be completely defunct the moment the baby is born. So the scientific bodies have discovered that if you extract the goodness of the placenta in the form of its biomolecules, you can still put it to clinical use. So by a proper sterilization method with heat and cold treatment to remove the chance of infections, a human placental extract can be obtained. And what does this extract contain? The extract contains multiple biomolecules which have now been proven irreplaceable in the process of tissue repair, anti-inflammatory activities, and a lot of healing processes. So some of the important biomolecules are the polydeoxyribonucleic acids and the nicotinamide adenine dinucleotide phosphate hydrogenase like compounds. You can see the list that is given here on this slide here. But what is more important is that each of these molecules have unique anti-inflammatory activities and activities that enhance blood flow at the local tissue level. It removes the ill effects of fibrotic scarring and helps in regeneration of tissue, preventing infection-related fibrotic damage. So the fibronectin type 3 and the ubiquitin-like peptides, these reduce the tissue adhesion and prevent new adhesion formation, so as to improve the luminal patency even in scarred tubes. So we'll come to that, how it helps in reproductive health, but it has the capacity of removing blockages that have been caused by previous scarring or inflammation. I don't know how many of you will remember, but I remember using the the amniotic membranes for burn dressing, and many of these situations where we had to use, large area dressings and in a more cost-effective manner, because the placental extracts have capacity to repair, regenerate, and reproduce biological tissue. Now, coming to reproductive health challenges, recurrent pregnancy loss, it has been one of the topics addressed in each and every conference, in each and every setting for the last so many years. And what have we come to finally? We've come to knowing that a lot of etiology can be defined, but at the same time, 50%, almost half of our cases of recurrent pregnancy loss remain undiagnosed etiology or unexplained. So suppose you have Mrs. X who's had 4 early miscarriages, couple karyotype is normal, thyroid stimulating hormone is normal, ANA profile is normal, no APL antibodies, and a 3D ultrasound is normal. How does that counseling go? The counseling goes round and round, where we keep telling the patient that, there is really nothing that I can offer you with evidence which is going to help you. Now, there is something called tender loving care, which has been appreciated in the guidelines that can be offered to this patient. But just saying tender loving care, is that enough. Similarly, there are these conditions of recurrent implantation failure where more than 2 or 3 transfers under IVF conditions have been done and they have not yielded into implantation. Now here there are again many reasons why there could be failure of implantation, but non-specific inflammation has been one of the reasons that has been explained, and similarly immune dysregulation with the Th1 and Th2 cytokine imbalance has been taken as one of the reasons for this kind of a failure. So because there is a non-specific immune dysregulation, non-specific problem with immunology in these two conditions, if we could reset the immunological barrier, maybe we would achieve success. And that brings us to the use of immunoglobulins, GCSF, all kinds of things in the treatment of unexplained recurrent pregnancy loss and unexplained recurrent implantation failure. Here, the placental extract, the human placental extract, provides a promising insight because you have a speculation that all these immune dysregulatory factors can get an automatic reset by the factors that are present in the placental extract. And this is an extract from a placenta, from a human origin, from a condition which is pro-pregnancy and therefore leads to good immune regulation, good inflammatory control, good angiogenesis boost, and good tissue repair and reproductivity. So it can help us create the kind of endothelial growth factors, reduce the adverse the cytokines at the cellular level, and promote endometrial enhancement and tubal function. Thin endometrium that has been identified as one of the causes of recurrent endometrial failure has seen to improve whenever we give tissues which help in the subendometrial blood flow. And the human placental extract has got the vascular endothelial growth factors and the other ubiquitin-like peptides which improve the subendothelial growth factor. So the epidermal growth factors as well as the vascular endothelial growth factor enhance the angiogenesis and the local tissue perfusion in the endometrium and help in improving the thickness of the endometrium, therefore leading to a speculation that they may help in improving the outcomes in conditions like recurrent pregnancy loss or recurrent implantation failure. It may be an off-label use, but the absence of evidence is not evidence of absence. Intramuscular therapy with the human placental extract provides a more or less cost-effective solution to non-specific immune dysregulation. How is it used? The clinical protocols that have been used in the past have suggested intramuscular injection of 2 milliliters of the human placental extract either daily or on alternate days for at least 10 to 20 days. There have been different protocols suggested by different study groups, and there is a need for now to escalate study in this area and create better evidence for our population, because it has been seen that there is definitely an improvement in the hormonal milieu, in the immune regulation zone when this human placental extract is used in certain conditions. Is there a safety concern there? Considering that it is a human placental extract, the safety concerns are mostly theoretical, and it has been suggested that we can explain it to the patient that there is an off-label use that we are doing here, but so far there are no reports of adverse reactions. These are some of the studies done in India where they have compared the use of human placental extract in ovulatory protocols with the use of different types of ovulatory drugs, and there has always been seen to be an enhancement in the results, because while ovulatory drugs help in ovulation, a simultaneous repair of the endometrium and a simultaneous sustenance of the endometrium is important for the final outcome of pregnancy. So the human placental extract has been seen to be rich in nucleotides and anti-inflammatory substances, the substances which enhance fertility by improving tissue repair, debridement, and hormone regulation factors. This was a study done by Dr. B.N. Purandare many years back, and this was published in one of our journals only, wherein they showed that just by the use of human placental extract in patients with chronic pelvic inflammatory disease, the incidence of fertility improved in that group which already had proven tubal blocks. So just by human placental extract, there was a improvement in the tubal patency. What I was telling you in the past, that there are factors in this particular extract which help in lighting the existing scars and improving the luminal patency of the fallopian tubes. Chronic pelvic inflammatory disease causes adhesions. We all are aware of this, which can lead to non-specific chronic pain as well as subfertility. And the use of the human placental extract has been seen to improve the symptoms in this particular condition. The tubal damage and complications because of various infections can be undone by the activities of the molecules at the cytogenetic level, because earlier we were using these extracts, but we didn't know why they work. Today, with the explanation provided by regenerative medicine, provided by the study of cytokines at the cellular level, we are able to understand why there is an inflammatory modulation and there is a debridement action, there's a collagenase activity by the human placental extract. Post-surgical wound healing, always there is a better outcome when you use the human placental extract, because the ubiquitin like pathway and the all other fibronectin like molecules help in wound debridement and help in better repair of the surgical wounds. So for us in obs and gynae, the post cesarean wounds as well as post laparoscopy laparotomy wounds or episiotomy wounds will have a good outcome if we use the placental extract there. The biofilms which are produced after a particular kind of infection prevent the activity of healing at that point in time, and the human placental extract has particular impact on these biofilms because the chronic non-healing wounds get better. And here I would like to bring to your notice that not only wounds here but also wounds like the diabetic I had somewhere. Yeah, the diabetic ulcers. The use of human placental extract has been done in the diabetic foot ulcers, where the neoangiogenesis at the root of these ulcers can be improved by using this particular extract, which creates new molecules there that help in the healing of this tissue. So versus conventional dressings, the human placental extract dressings have been seen to be improving the outcome in diabetic foot ulcers. In reproductive health, what are the other areas where we could consider the use of human placental extract? One of them is cervical erosions. Again, vaginal dryness, cervical erosions. We know the problem with hormone-based treatment in vaginal dryness and in cervical erosions. We really sometimes are at a loss as what to prescribe, which does not do harm, does not cost a lot of money, and still can be accepted by the patient. And there is an opening here where we could use the human placental extract. When we are talking about placentology and thinking of multiple uses of the placenta, what happens to the placenta in situ is already being studied and already being understood. But once you remove the placenta from the body, can we still extract some goodness and use it in clinical medicine is the next line of thought. In this era of regenerative medicine, where regenerative medicine also looks like a very expensive thought, this is one of the cost-effective regenerative medicine options. And I am sure we can in ICOG come together and generate evidence, or at least study. If you still have doubts about this use, let's study it. So we can create study protocols and use the human placental extract in these areas of reproductive health and generate our own evidence for that. So these are some of the studies that have been done so far with the use of the human placental extract gel, especially in cases of cervical erosion. And so far, the milestones have shown that there has been significant improvement. The Placentrex gel has been known to help in the reepithelialization process, and therefore it has definitely made a place for itself in the wound healing process. Now, in endometrial regeneration, it solves the core problem. There is a multi-target mechanical advantage because the epidermal growth factor, the vascular endothelial growth factor, all the anti-inflammatory growth factors seem to improve the overall clinical outcome. So as of today, the use of human placental extract is very potential. And I have used this complex Venn diagram just to show that there are multiple intertwining of pathophysiologies. So whether it is about wound healing, whether it is immunomodulation, whether it is endometrial regeneration, or all the things that we are considering here, there are multiple overlapping pathophysiological mechanisms. And here there will be a role of the human placental extract, because repairing, regenerating, and reproducing is the basis of all that. Again, absence of evidence is not evidence of absence. So I request the astute academicians of ICOG not to write this off, because as of now we don't have enough evidence, but to come together and help us generate evidence by making studies possible in this case, so that we can collect data and use the human placental extract for novel uses in reproductive health. Think new and first do no harm. Thank you very much for a very patient hearing.
Thank you, Chinmay, for that wonderful lecture and bringing us back to the use of the organ which we think is disposable organ. In my student days in Kama Hospital, I remember there was one big, very, the deep refrigerator, and every evening the person from some injection company
Yes.
used to come and collect all the
Yes, madam.
placentals. And I used to say, what are exactly you're doing? Then that was an injection placentals that time, which you have mentioned the period of Dr. B.N. Purandare. Of course, I am not from that era, don't consider that, but because in front of my own eyes, and we used to give them the placenta. So since that time, we know the value, but later on, I think it got dilated, and today again, we are focusing again of the uses of the placenta, and I'm extremely happy that I was a part of that placenta, saving the placenta mechanism and making it to the patients. So you very well said that it is ovarian rejuvenation, thickening of the endometrium, infertility, male infertility, PIDs, and whatnot. So it is like I can compare it with the stem cells, which we, regenerate from other cells, and it is already there. So I think Chinmay has thrown a very big, opportunity, I can say, for the researcher, for the ICOG people, that we must really think whatever is already available. We are having 11,000 deliveries in Kamavan, only one hospital. How many deliveries are there? So we should take use of this already existing and almost, throwing that into the dustbin. We must, yeah. So, I think wonderful lecture, and you given a thought for our this thing for thinking and for the research. So thank you very much.
Thank you, ma'am.
Yeah, thank you, Chinmay. I think I can see Dr. Manjupuri's remark in chat box. Yes, I think we as a seniors, I think we have been using it in PID for a long time. Okay, earlier, yes. And the placenta collection, madam, yes, I also remember where I worked, the placenta was collected, and day by day as we are learning more and more. And I must tell you, recently, Indian Institute of Science has approached me for a study to study the mother's blood, then the cord blood, and the placenta and the amniotic fluid to assess the mirror images of certain metabolic disorders. Okay, we are working on that. So definitely, I think placenta is also there in that, and many things will come out through that, and we will know that how we can use this molecule more and more. So as Madam Mandakini said, research. I think we will need more research. That has been already said. So thank you once again, Chinmay. Yeah.
So we have our next speaker, Dr. Upma Saxena, who is here. Can we have a CV on screen, please? Shreya? Sheila madam, you're muted.
Yeah. So now Dr. Upma Saxena, again, I must say that all my governing council has come together for this, and she's also a co-convener. She's an in-charge fetal medicine and genetic clinic, and she's a chairperson of that committee of AOGD currently, and a GC member of ICOG and executive committee member of SFM Delhi chapter. There are so many publications to her credit, many scientific papers, citations, and papers also. So over to you, Dr. Upma. Yeah.
I'll start sharing.
Molar placenta.
See my PPT?
Yeah,
So it's
make a
very heartening to
slideshow.
note that
I'm
we
making
have
it slideshow.
Yeah,
we
slideshow.
have crossed more than 550 participants simultaneously at one stage. Even now, it's close to 500.
I told you are Dhurandhar of the subjects.
Thanks. Good evening, respected chairperson, Dr. Mandakini and Dr. Sheila ma'am. And thanks a lot for giving me the opportunity. So I'll be talking all about molar placenta. So gestational trophoblastic disease, GTD, is the term used to describe the heterogeneous group of interrelated lesions that arise from abnormal proliferation of placental trophoblasts. The benign lesion consists of complete and the partial mole, and the malignant lesion consists of invasive mole, choriocarcinoma, placental site trophoblastic tumor, that is PSTT, and epithelioid trophoblast tumor, ETT. The malignant lesions, referred as gestational trophoblastic neoplasia, are diagnosed by persistent beta HCG and have varying propensity for local invasion and metastasis. Beta HCG is critical marker to diagnose the development of GTN, monitor response to chemotherapy, and occurrence of relapse. GTN are rare rupert that can be cured even in the presence of widespread metastasis. So histologically, we can classify GTT into benign, complete, and the partial mole. And the malignant component are invasive mole, choriocarcinoma, PSTT, and ETT, which together are known as gestational trophoblastic neoplasia. Incidence is much higher in Southeast Asian countries. In India, the incidence is 1 in 4 per 1,000 pregnancy, with H mole being the most common. The most important risk factor is extreme or maternal age, and the recurrent molar pregnancy is associated with chromosomal mutation. Coming to the complete mole, it occurs when an empty ovum is fertilized by a haploid sperm which duplicates to form a homozygous pregnancy, or when an empty ovum is fertilized by two sperm leading to a heterozygous pregnancy. So molar chromosomes are entirely of paternal origin. Maternal chromosome either absent or silent. So there is no embryo, and the terminal villi are transformed into grape-like vesicles. In case of a partial mole, the ovum is fertilized by a extra haploid sperm leading to triploidy. So maternal chromosomes are present, so fetus is present, but this fetus is triploid and it has many stigmata like FGR and multiple congenital anomaly, as you can see, hydrocephalus and syndactyly. This hydatidform swelling of the chorionic villi and the trophoblastic hyperplasia, it is diffuse, as you can see in a complete mole, and it is focal in case of partial mole. While fetal embryonic tissue, scalloping of the chorionic villi and trophoblastic stromal inclusion is seen only in the partial mole, not in the complete mole. So in case of complete mole, there is a hydatidform degeneration of the chorionic villi, and they have the malignant potential for invasion. So after molar evacuation, the local uterine invasion, that is invasive mole, can occur in 15% and metastasis in 4%. The most common clinical presentation is irregular vaginal bleeding and passage of grape-like vesicles. The other symptoms are not seen so commonly nowadays in complete mole because of the early diagnosis, as most of them are diagnosed with the ultrasound. In case of a partial mole, these symptoms, typical symptoms are not seen, and the women usually present with symptoms of incomplete or missed abortion, and the diagnosis of partial mole is clinched on histopathology. So, POC of all missed abortion should be sent for histopathology to make a diagnosis of partial mole, which need beta HCG follow-up. So UPT should be done once you suspect it, and a quantitative estimation of serum beta HCG to be done. Complete hemogram, KFT, LFT, and TFT. Ultrasound is the modality of choice, and the gold standard is the IHC 57, which is a nuclear protein whose gene is paternally imprinted and maternally expressed. So this is negative in case of complete mole, and it is positive in case of a partial mole. The flow cytometry help us to determine the ploidy. So complete mole is diploid and negative for P57, and the partial mole is triploid and it is positive for P57. So in a complete mole, on ultrasonography, the ovaries show typical multiple theca lutein cyst, and in the uterus, we see multiple small anechoic cystic spaces without fetus or amniotic sac, giving a typical snowstorm appearance. The villi in complete mole exhibit diffuse hydropic swelling, which gives a characteristic vesicular pattern. However, in case of partial mole, we see a thick enlarged multicystic placenta with the fetal tissue. In complete mole, suction curettage is the preferred method of evacuation regardless of the uterine size. So according to the FICO update 2021, the diagnosis and diagnosis and management of GTD, suction evacuation and curettage should be ideally performed under ultrasound guidance using 12 to 14 gauge Carmen cannula. Uterotonics are not recommended before the procedure due to the risk of tumor embolization. However, they can be given during the procedure and after the procedure to enhance uterine contractility and decrease the blood loss. After the suction evacuation, we can go do a gentle sharp curettage and complete tissue should be sent for histopathology. In case the uterine size is more than 16 weeks, then adequate blood for transfusion should be made available. Anti-T prophylaxis should be given to Rh negative women. If the women age is more than 40 years, then we can counsel her for hysterectomy because it eliminates the risk of locally invasive mole. However, she should be counseled that beta HCG monitoring will still be required. The medical induction of labor and hysterectomy are not recommended because they increase maternal morbidity and also increase the risk of post-molar GTN. Prophylactic chemotherapy should be done only if the risk of post-molar GTN is much higher or when adequate HCG follow-up is not possible. So after molar evacuation, local uterine invasion, that is invasive mole, can occur in about 15% of the patient and metastasis can occur in 4%. Hence, patient should be monitored with weekly beta HCG until levels are normal for 3 consecutive weeks. Beta HCG levels become undetectable by 9 weeks in a complete mole. After beta HCG normalization, monthly beta HCG measurement should be done for 6 months in a complete mole and for 1 month in a partial mole. During this surveillance period, the contraception of choice is combined OCPs, DIMPA, and implant. MTP is not indicated if accidental pregnancy occurred during the surveillance. There are diagnostic criteria for post-molar GTN according to FICO, and these are when there's plateauing of beta HCG lasting for 4 measurements over a period of 3 weeks or longer, when there's rise in beta HCG for 3 consecutive weekly measurements over at least period of 2 weeks, or there is a histological diagnosis of choriocarcinoma, persistence of beta HCG, or presence of metastatic disease. So coming to GTN, I have just told you it is either invasive mole, choriocarcinoma, or PSGT. Invasive mole is characterized by aggressive invasion of the endometrium and the myometrium by the trophoblast cell, and there may be metastasis. The risk of invasive mole after complete mole is 15%, and it is 0.5 to 5% after the partial mole. So invasive mole always originate exclusively from complete and the partial mole, but they have to be treated with chemotherapy to prevent morbidity and mortality caused by perforation, hemorrhage, or infection. Women with invasive mole usually present with irregular vaginal bleeding, theca lutein cyst, uterine subinvolution, and persistently elevated serum HCG. The persistent GTN occurring after molar evacuation could show the histological features of either H-mole or choriocarcinoma. However, after a non-molar pregnancy, they will show histology of choriocarcinoma, which is characterized by sheets of anaplastic syncytiosopoblast and cytotrophoblast without the chorionic villi. Choriocarcinoma is extremely malignant. It's very vascular and develops early blood-borne metastasis. And it may arise from any type of pregnancy. So it could be either molar or it could be abortion, ectopic, or even after term pregnancy. Coming to metastatic disease, it occurs 4% after the molar pregnancy, but it is seen more commonly after non-molar pregnancy. And the more common site of metastasis are lung, which is seen in almost 80% of the cases, and it is seen in the form of cannonball appearance or a snowstorm appearance. In vagina, it occurs in 30% cases, and in liver and brain, the metastasis occur in 10% of the cases. So any women in the reproductive age group who present with abnormal bleeding or evidence of metastatic disease should undergo a beta HCG testing to rule out GTN. Coming to the FIGO staging of GTN, the stage 1 is when the disease is confined to the uterus. Stage 2 is when it has extended outside uterus into the pelvis. Stage 3 is when the GTN has extended to the lung with or without non-genital tract involvement. And stage 4 is when it has metastasized to other organs like liver, spleen, and brain. So there's this WHO prognostic risk scoring, there are 8 things which we score 0, 1, 2, 4. And when the score is less than 7, it is a low risk. And if it's more than or equal to 7, it is a high risk. So patient with stage 1 disease are low risk and patient with stage 4 are high risk. And the distinction between the low and high risk applies mainly to the patient with stage 2 and 3. And to the stage, we allot a Roman numeral, and to the score, we allot a Arabic number. So a stage should be followed by a colon, and then it should be with the scoring system. And this should be done allotted to each and every patient of DDM. So coming to the management, in stage 1, we treat it with single agent chemotherapy. Stage 2 and 3, which are low risk, we again treat them with single agent chemotherapy. But if it's a high risk, then we have to give combination chemotherapy, which is usually IMACO. In stage 4, we do combination chemotherapy, that is IMACO, along with we have to manage the metastasis in the brain and the liver. So just the lung metastasis can be diagnosed by doing an X-ray test or by CT scan. Liver mets may be diagnosed by ultrasound or CT, and a brain mets can be diagnosed by a MRI or CT. In case we are not able to see the brain metastasis, we can do a spinal tap, and the ratio of plasma to CSF SCG tend to be lower than 60 in the presence of cerebral metastasis. So again, stage 1 is low risk, stage 4 is high risk, and stage 2 and 3 only you have to do this WHO prognostic risk scoring to know whether it's low or high. So DDM is recognized as only malignancy where chemotherapy can be initiated based on clinical evidence such as high beta HCG level and typical imaging finding without prior histological confirmation. So a low-risk DTM has to be treated by a single-agent chemotherapy, and the most common regime we use is methotrexate folinic acid 8 days regime, and we have to repeat it every 2 weeks. We can also use IV methotrexate and actinomycin. High-risk DTM, that is when the score is more than 7 in stage 2 and 3, and whether with the women in stage 4, then we have to use the IMACO regime. So this IMACO regime uses etopside, methotrexate, etopside, actinomycin, methotrexate on day 1, and day 2 it use etopside, actinomycin, and folinic acid. And day 8 we use vincristine and cyclophosphamide. In case patient is resistant to IMACO, then we have to treat it with we can replace this vincristine and cyclophosphamide by etopside and cisplatin when it becomes EMA-EP. And in case of IMACO, these 2 regimes that which last for 8 days has to be repeated. We have 2 regimes alternate each week. So after normal beta HCG attained, at least 3 additional course of chemotherapy administered to reduce the risk of relapse. And follow-up should be done weekly until it's normal for 3 weeks, and then monthly until it is normal for 12 weeks. And again, the effective contraception has to be used during this period. So resistance to chemotherapy is diagnosed if beta HCG level plateau over 2 weeks or it re-elevates in at least 1 measurement. So again, low risk GTN, then we have to start single agent chemotherapy, which could be either methotrexate and actinomycin. If there is resistance, we have to give combination chemotherapy. In case of high risk GTN, we have to give primary intensive combination chemotherapy, that is IMACO, along with the selective use of radiotherapy and surgery, and we have to manage the hepatic and cerebral metastasis. Coming to ultra high GTN, it is said to be when the prognosis score is more than 12. Here, if we start with standard chemotherapy, it may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia, and multi-organ failure, all of which can result in death. So we have to do induction with etopside and cisplatin on day 1 and 2, repeatedly weekly for 1 to 3 weeks before starting full dose therapy. In case the combination chemotherapy fails, then we have this salvage therapies or alternative therapies, which besides using drugs chemotherapy, also we can use autologous bone marrow or stem cell transplantation and immunotherapy. Coming to the role of hysterectomy, it should be done only if there is a life-threatening intraperitoneal hemorrhage due to invasive mode, or there is persistent low-level beta HCG due to the residual disease, in case the patient who are not willing for follow-up. Ovaries may be preserved at the time of surgery. If there's large ovarian cysts, we can decompress them by aspiration. Adjuvant single-agent therapy can be given to reduce metastasis at the time of hysterectomy. Hysterectomy does not prevent metastasis. Patient still needs regular follow-up with assessment of beta HCG. So in case of PSTT and ETT, these are they're metastasized lymphatically, so they are chemoresistant. So we have to go for hysterectomy with lymphadenectomy. Coming to the role of radiotherapy, in one case there is a brain metastasis, Irradiation is hemostatic and tumoricidal, so the risk of spontaneous cerebral hemorrhage is lessened by it. Concurrent use with combination chemotherapy. The recurrence of molar pregnancy is very less, it's 1 to 1.5%. And all patients of molar pregnancy and GTN should be counseled that they can expect normal reproduction in the future. However, for any subsequent pregnancy, we have to perform first trimester ultrasound to confirm a normal gestation development, and beta HCG should be done 6 weeks after pregnancy to exclude occult trophoblastic neoplasia. So to conclude, complete mole is diploid and negative for P57. GTN commonly follow a molar pregnancy, however, they can occur after any pregnancy. Follow-up with beta HCG is crucial in diagnosis and management of GTN. Early recognition is essential to prevent complication. POC of all missed abortions should be sent for histopathology to make a diagnosis of partial mole. Any women in the reproductive age group who present with abnormal bleeding or evidence of a metastasis should undergo beta HCG testing to rule out GTN. Stage and score is allotted to each patient separated by a colon. GTN is the only malignancy where chemotherapy can be initiated based on high beta HCG level and typical image finding without prior histopathology. Prognosis is excellent even after widespread metastasis. Thank you.
Thank you, Dr. Upma Saxena, ma'am. Excellent lecture, very evidence-based, precise, and you finished dot in time. I think
Thank you.
it's something which is highly appreciated by us as the organizers as well. If there are any
Thank you.
questions, we will take them in the chat box. We have 5 minutes for discussion before we go to the next session. If there are any important questions, may the conveners please take them up.
Thank you, I think, Upama. And one important message you gave, that missed abortions, if we are doing, I think, MBA, then that should be sent for histopathology. But nowadays, we have most of the time it is MMA. At least it is, in case of missed abortion, it's better to repeat the beta HCG levels after 6 weeks, I think. I think at least that will help, because most of the patients are undergoing MMA. So in that case, we cannot send it for histopathology, but after 6 weeks, we can do beta HCG. And I think that message you gave, I think that was a very good message. And everything about the P057 and everything. Thank you. So thank you both the speakers for excellent job, Chinmayi as well as Upma.
Thank you, Chinmayi and Upma. Excellent talks.
Thank you, ma'am.
So shall we go to the next session then? Thank you very much to the two speakers of the second session, and of course our chairpersons, Dr. Mandakini Meg and Dr. Sheila Mani ma'am.
Was one question regarding anti-D. Whether to give anti-D after the evacuation in molar pregnancy.
Even FOGSI madam says that it should be given.
Yeah.
Because earlier there was thought that it doesn't contain the RBC, but it's better to give. Even FOGSI guidelines say the same.
Yeah, that was the question in the chat box. Yeah.
So, ma'am, the thing is, complete moles may not have an antigen, but then the result of histopathology takes more than 72 hours.
Yes.
And the time to give the anti-D is within 72 hours. Therefore, it's better to give it.
I think irrespective of HPE, that's all.
Yeah.
I think said that. Yes.
I think, Dr. Upma, you can take on the next session.
Introduce the chairpersons. Thank you.
Now we will move to the next session. Can have the next session will be chaired by none other than Dr. Shobha Goody, madam, and Dr. Shobha is HOD at St. Philomene Hospital, Bangalore, and I think she needs no other introduction. She is the current Vice President of FOGSI, and I welcome her, madam.
Sorry, Upma, I'm the VP elect. I'm the VP elect.
Okay,
Not
she's
the
VP
current
elect.
VP. Yeah.
Current
Okay.
VP
She's
is
VP
Dr.
elect.
Vidya Thobi, who is attending. We welcome you, Dr. Vidya.
So can we have the next slide of next chairperson? Next is Dr. Mita Saxena. She is also VP elect, and she's also the governing council member, and she is a great academician, and she has a nursing home, which we know she's taking very good care of her patients. So can we have the next CV? Dr. Sneha Bhuyar. She needs no introduction, and she also owns a nursing home and at Pune, and so she's owns at
Yavatmal, it's not.
Neha ma'am is from Yavatmal. She has
Yeah,
made Yavatmal famous
Yavatmal,
in
Srinath,
FOGSI.
and
Yavatmal
I think she is
is
also doing a very good job. She's her, I think, clinical management of the patients is very good. I keep her. I mean, I have seen many patients from referred by her to Safdarjung Hospital. She's taking good care of them. So next, we will be coming to the other. So I'll request the chairperson of the next session to introduce Dr. Prashant Acharya.
Okay,
No, sorry, mistaken. Yes.
shall I introduce the first speaker? Yeah.
Yes, ma'am, please.
So,
Yes.
so thank you, immense thanks to Dr. Sheila Mane and Dr. Pratik Tambe for including me as chairperson in this vibrant session. Thank you, Chinmayi, for that special invite. And I have been listening to one or two of the past lectures because I had an EC meeting, important one here. I'm sorry I joined a little late, but what a wonderful academic session. Really brainstorming and a subject which needed more insight by all clinicians should have more insight into this. It was a bit neglected field. So it is my privilege now to introduce Dr. Prashant Acharya. Yeah. Okay, the CV went away.
Can we please have Prashant sir CV?
I'm so sorry.
He is a very well-known fetal medicine specialist.
Very well-known fetal medicine specialist,
Sir has
very
put up his
sought
CV.
after, very sought after. Founder secretary for Fetal Brain Society. My goodness, I didn't know such a one existed. And
done
he's
lot of on
ICOG
brain.
fellow. Yes, ICOG fellow 2019 and ICOG board member as well. So we welcome you, Dr. Prashant Acharya, to deliver your talk. Please start.
Yeah, Sheila, I just want to say one word about Prashant. Myself, Lakshmi, and Prashant were of the same batch of the vice presidents, 2011-12, if you remember. So luckily, we all are present here on this platform. It shows the popularity of your ICOG course. So
what a
welcome.
coincidence. What a coincidence.
What a coincidence.
Welcome, Prashant.
A lovely topic of multifetal pregnancy. I'm sure everybody will enjoy. So here goes. Thank you, Dr. Acharya, for being here. Please start.
I think sir's video is off.
Sir, your audio, we can't hear you. Prashant sir.
Am I audible now?
Yes,
Now
sir.
you're
Yes.
audible.
No,
Yes.
I think he joined without audio.
Perfect. Thank you. Thank you very much again, Chinmay and the team ICOG for inviting me to share something about how to look for the placenta in the first trimester of the pregnancy, and particularly the multifetal pregnancy. See, more is not merrier. Everything more is not very good. Here it's the same thing with the pregnancy. You have got twin pregnancy, still okay, but what about this quintuplet? What about the monochorionic pair and one separate fetus? This is a twin pregnancy, two separate placenta. I'm all okay. But the placenta is one of the very important point. Now, to understand the placenta, you need to understand the zygosity. The zygosity means how many embryos were formed. Whenever it's a dizygotic, means there was one ovum, another ovum, another sperm, another one more ovum, one more sperm. So there are two overall pregnancies which are formed initially, and that's how it will have its own placenta. This will have its own placenta. They will get feeding, and there are no communication whatsoever with each of these dizygotic twin. And the sex can be same, it can be different, and that's what is something about dizygotic. Now, monozygotic twins, that means only one ovum, one sperm, single zygote which is formed, and then it can split, and that's what you have these kind of pregnancies, and that is a possibility of you may have from that you may have a diamniotic dichorionic, and you may have monoamniotic dichorionic, monoamniotic and monoamniotic monochorionic, and many possibilities, and we are going to discuss all of them. So just remember rule of 3 in case of when you are talking about monozygotic twinning. the moment the sperm gets into the ovum, if it divides into first 3 days, it will end up in 2 separate placenta and 2 separate fetuses. So it is a diamniotic dichorionic. So the importance of diamniotic dichorionic is they don't have any relationship whatsoever. They will be of same sex, but if one fetus dies, nothing is going to happen to the another fetus. But the moment it splits between 3 to 9 days, it will have single placenta and 2 separate sac. Between 9 to 12 days, it will have a single sac, single placenta, and after 12 days, a conjoined twin, which is going to happen. Now, I'll let me make it more simpler thing. These are the incidences. This is theory. I won't go into the theory. Otherwise, the crux of the matter will go off. So simple. You have, after pregnancy which is formed, you will have one placenta, one amniotic sac, and there's going to be a fetus inside. So if you have got, so fetus will be supplied from the same. You have got, in case of diamniotic dichorionic, this is the situation. One more zygote, one more fetus, and they are diamniotic dichorionic. It has got nothing to do with each other. But when these happens in first 3 days, a similar kind of picture, but here they will have same sex. It may have a different sex, but this is what you may end up in first 3 days. After between 3 to 9 days, it will have single placenta, but 2 sac to fetus to live in. Here the issue is what? It has got a shared placental vascular architecture, and which is going to be supplied by both the fetuses. The problem is very different here because there are vascular communication. The complication of these monochorionic twin will happen because of that. After between 9 to 12 days, it will have single placenta, but the sac becomes single, and there are 2 separate fetuses which are going to be like this. So this is monochorionic monoamniotic, which is MCMA, again same, sharing the placental vascular architecture. It will be supplying the same, and after 12 days they will have conjoined twin, so that they will be stuck either by head, thorax, or abdomen, or anything else. That's what a primary thing. Here you have 2 sperms and 2 ovas. Here it is only one ova, one sperm, and it divides into the different kind of pregnancy. That's a basic understanding of understanding the placenta. There are simple. Old technique was looking at a thickness. If you have got the thick membrane, which is more than 2 millimeter, it be considered as a diamniotic dichorionic. Diamniotic dichorionic means one fetus has got nothing to do with each other. But primarily, you will have some bulging of the placental tissue which gets in between the membrane, and this membrane is very thin, less than 2 millimeter. Look at the thickness, which is more. This is very thin membrane. And now this is what typically we look at, a 2 membrane which is thick here versus 1 membrane which is we consider as a monochorionic pregnancy. But primarily now, because of the new ultrasound technique, you can even delineate one amniotic membrane, another amniotic membrane, and this is the space where some of the tissue of the placenta which gets into it, and this is classical diamniotic pregnancy which can be seen. Now, intertwined membrane, it has got a classic characteristic between these two, monochorionic and a dichorionic pregnancy. Now, if you really look at these pregnancy, you have got, this is dichorionic pregnancy. This is what is called as lambda sign. This is the T sign. It may have the single placenta in case of dichorionic twin. In case of dichorionic twin, it may have separate placenta, whereas in monochorionic, which is sharp attachment, look at this sharp attachment towards the placenta, not towards the uterus. So this you have to look for, not this end, you have to look at this end. This is going to have a sharp insertion without any placental tissue in between 2 layers of the membrane. So it has got a classical characteristic. Let us discuss about these dichorionic twinning. It will have a thick chorionic reaction in between the sac. You will have a classic lambda sign which will be visible. And these, look at even at early pregnancy, you will this lambda sign which will be visible, or look at the lambda sign on 2D which is going to be visible. And this is very simple, which is diagnostic almost in 99%. And that's what I have shown you. I have shown you how to look for this intertwin membrane, and it is going to be thicker, more than 2 millimeter, which has got a positive predictive value of almost 95%. So if you see more than 2 millimeter, if you say it is dichorionic, 95% you are going to be right. That means 5% wrong. So always look at a T and the lambda sign, and that is how you should be looking at this antenatal sonography prediction of chronicity, which has got, if you go earlier before 14 week, you are going to be correct in almost more than 90%. Look at in the second trimester, it falls. So always and always predict. There are no twins. It is either monochorionic or it is a dichorionic. So there are no multifetal pregnancy, no triplet. You have to define it is trichorionic triplet or it is monochorionic pair with a trichorionic triplet. I mean dichorionic triplet. So that's how you have to define it, and that's what makes. Otherwise, because the complication rate are so different, and that's the reason you need to identify. Look at this placenta. It is you can see that there is this insertion. Look at this placenta again. This is classic dichorionic. This is classic monochorionic. You will see a typical triangle, but without any. Look at the thickness. This thickness is much more than 2 millimeter. Look at the very thin placenta. So that's what I wish you understand this. Again, I'll show one more. This is dichorionic pregnancy. This is a triplet pregnancy. This is 1, 2, and 3 fetus. Look at this is a dichorionic sac. So this is a separate fetus, and these fetuses are single. This is the pair monochorionic, and it has got a very typical, very different prognosis. A simple triplet with 3 different sac, it has got a complete different outcome, whereas this dichorionic may have a distinct placenta. This placenta which is separate. This is separate placenta. There is no confusion whatsoever. And the problem is, when you have got a monochorionic twin, it will have many kind of problem. Now let me explain what is the problem with monochorionic placenta. Whenever you have these kind of monochorionic placenta, and this membrane inserts on the placenta just like this, without any thickness of the placental tissue in between the membrane. I think let me we all are obstetricians. Primarily, we have tendency to throw the placenta after delivery into the garbage. Please have a look at this twin placenta after the delivery. Lift the membrane, especially in the monochorionic twin after the delivery. Make sure that if you have look at a placenta, then you understand the typical thing about what are the complications, why this complication happens. I'm showing you 2 distinct placenta. Let me show this first. What I have done is I have injected red dye in this and green dye here in this placenta. Okay, now just look at this area. This is what we call the crater. One placenta ends here and another placenta ends here. This green dye stops, red dye stops. But the issue is this: I'm okay with this kind of configuration. But the moment you go, just look at this below, this segment. This green dye is going from the surface of the placenta on this side. That's the problem. In monochorionic placenta, because the vascular architecture is this, the blood vessel, this is the surface of the placenta, surface communications. But there are deep communication can happen inside the placenta. Look at the video on your left-hand side. I'm just lifting the membrane and look at this vessel. Let me draw. This is the vessel. It goes here. It goes in the substance. But look at this vessel. It goes in the substance here, and this vessel crosses the membrane and it is supplying the other side of the placenta. The meaning is simple. that whenever this kind of situation is there, this blood supply can go. There's a deep communication which happens, and these deep communications are that this is one deep communication. Then I will show you. This is one more deep communication which may takes you the blood vessels from one side to the another side. This is one more. I will show one is here, which is coming from here to on this side. This is going from here to other side. Look at these artery which goes from one to other side. Now, why there is a problem of this communication? To understand this, I will probably draw one single rule. I'll give you an example of one drum and another drum. If there are both drums are separate, and if one gets leaked from one drum, the another drum is not going to empty it into another the same drum. That is a dichorionic placenta. It has got a separate communication. This has got a separate communications, and all sorts of problem happens when you have got these vascular communications. So the basic problem is these communicating vessels. Whenever there is a problem in one fetus, if baby is having severe hypoxia, maybe one baby is having twin-to-twin transfusion syndrome or a selective fetal growth restriction, and when that baby doesn't get sufficient blood and is about to die, what will happen? Any human being which is about to die will have severe irreversible hypotension. And that hypotension will create a pressure gradient from a normal blood pressure, normal fetus, to a hypotensive fetus. Blood will drain into the abnormal fetus. So that baby is dying, it will die, but it will take these monochorionic twin along with it. So that's exactly what the problem. And that is the reason why you have got monochorionic and a dichorionic twin pregnancy. Monochorionic twin pregnancy will have 5 times more miscarriage, 5 times more perinatal death, 15 times more chance of fetal growth restriction, preterm birth double, and a major defect 4 times. So that's the reason you need to understand this chronicity. And there are all different kind of defects which can be possible. Let me. This is what you can always read. This is a theory. I won't go into the theory, but complication unique to this is traps and twin-to-twin transfusion syndrome. This is like dichorionic twin pregnancy. When you have got a leaking or some kind of problem, nothing will happen to other. But whenever you have got a monochorionic pregnancy, if the one fetus has got complication like selective fetal growth restriction or a twin-to-twin transfusion syndrome, or when there is a complication, it will die. So the another fetus will also die. So make sure that you have understood what the vascular architecture which is common, and that is creating problem to monochorionic as well as dichorionic pregnancy. And that is the reason you should understand that whenever in a case of dichorionic pregnancy, one fetus is compromised, there is no major problem to the another, because it has got a different placenta, different genetic makeup, different sex is possible. So if one fetus about to die, there is no problem to the another fetus. And antenatal care is completely different in a dichorionic twin pregnancy as compared to the monochorionic twin. But the problem is when there is a monochorionic twin pregnancy, like single placenta, these are like 2 drums, they are communicated. So if one drum gets emptied, the another drum also will get emptied. And that's the problem, because there is communication will lead to equilibrium in the volume and the pressure. So if one baby dies, another baby also going to die. And that is the primary fundamental fact about understanding the placenta. So if one fetus is compromised, there are major problems with others because of the same placenta, same genetic makeup, same fetal sex. And if the one fetus is about to die, in majority of the case, another fetus will also die, or it will end up in severe CNS defect, because there is going to be a compromise, severe hypotension. Because of that hypotension, it will have neurological damage, which is going to happen to this monochorionic surviving twin. So make sure that you investigate them appropriately. I'm just giving you one highlight. What is the difference between the monochorionic twin and the dichorionic twin placenta? If at all you have got, if you find a monochorionic placenta, make sure that you evaluate every 2 weeks. Look at the growth discordance between the CRL, DV, and NT. That is what is needed. It is not only the measuring of NT. Consider the difference in the CRL and NT value and the ductus venosus value. What's the discordance, and try to understand. Second trimester, not only regular evaluation of both the fetuses. You need Leica assessment. You need to add all Dopplers like MCA PSV, ductus venosus, and umbilical artery on the side of the bladder, never on the free loop of the cord. And the same thing you should evaluate in the third trimester. And that is how you should evaluate this monochorionic and the dichorionic pregnancy. This is how I always try and evaluate the placenta by 3D. Count the placenta. After 10 weeks, please look at a lambda sign and the thickness of the placenta. Thank you very much for patient hearing.
Dr. Shobha, madam. Dr. Shobha, are you there?
Excellent.
You are muted, madam. You are muted, madam.
Thank you, sir.
Yeah.
You are muted, madam.
Not allowing to now.
Yeah.
They were not allowing me to unmute. Yeah,
Same.
excellent presentation, Dr. Acharya. Nothing less was expected, I think. But then also, this is a very huge topic, but you have so wonderfully covered in the salient features in a short time, and you have given a lot of clinical perspective. And I think every trimester, every visit is precious. And today, I think all obstetricians depend on sonology to manage the twin pregnancies. And the complexity of monochorionic placenta was beautifully brought out. Thank you so very much. Any questions are there, Chinmay? You can just check. Otherwise, we can move on.
I think we can have the questions at the end of that
And
session.
then, fine.
Yeah.
We'll go
So
on
I'll
to the next,
request
please. Yes.
Dr. Mitra to invite our next speaker, Dr. Sita.
So
If you can, because I will be going. So if at all you have some question, I'll take it first because I won't be able to join. So
yeah,
if at
right now,
all there is a question.
If at all. Anybody has a question, please respond. Because sir has to
Compliments. No questions, compliments.
There's
Only
no question
compliments
there
for you.
except for one thing, prognostic value of subchorionic fibrin.
At the moment in the first trimester, when there is a subchorionic fibrin which is there, I will always investigate them for possible associated antiphospholipid or any other syndrome. That's what I will add. That is the only thing which I'll add in a day-to-day clinical practice. I investigate them for thrombophilia and associated malformations. That's what I always do. Otherwise,
Okay, Shweta has a question. Why uterine artery Doppler is not done in twin gestation?
in twin pregnancy.
Yeah, that's what is the question. Because we do routinely. So.
Because the role of uterine artery is not
It's
yet
limited.
well defined in case of twin pregnancy.
Not defined.
And
But
as a
it
twin
will
pregnancy has got
It's a
already more
high
than
risk.
10% chance, already more than 10 to 12% chance of preeclampsia already. So they are
They
already
become
into
a
the
high
high
risk.
risk category. So there is no point in identifying, putting more in higher. The higher risk has got no value. It's already risk
Most
category.
often, the gestosis score itself will tell us to start low, low dose aspirin. Yes. Okay.
So, madam,
With that, we can move on.
Twin aspirin is again a controversy.
Okay.
But don't combine both of things because it has got a different value of aspirin and a twin pregnancy.
Okay.
There are no specific yet studies where aspirin, if you add aspirin to a twin pregnancy in all, by default will improve the outcome. Yet not proved that part.
Okay. What if chorionicity has not been assessed in earlier scans and the patient comes to us in late second trimester for a scan?
Consider them as a monochorionic and follow them as a monochorionic. Simple rule. If you have not defined them as a dichorionic, all pregnancy needs to be considered as monochorionic. You have to add frequency of ultrasound and you have to add the Dopplers. Ductus venosus, MCA PSV, and umbilical artery paravesical, not in free loop, nowhere else except paravesical. Please don't do umbilical artery anywhere else if you are talking about a twin pregnancy.
Excellent. A large
Why?
subchorionic hematoma.
Sir, why
This is
also
the
please
last
explain
question.
why?
There is a reason, madam, because in a free loop, which that loop is of which fetus A or B, you have
will
no
not be
idea.
able to.
So please do not ever take a free loop. And if somebody is taking it a free loop, if you are referring them, please don't refer. Simple. You will be end up in a disaster.
This is the last question, Upma. A large subchorionic hematoma management.
The subchorionic
Little
hematoma,
digress.
it's all about where it is located. If it is located near the placental insertion of cord, it carries more weightage than the peripheral. Then there are just beneath the membrane, there may be collection. It has got technically no value. So adding progesterone to submembranous hematoma has got no value. If at all you were to add something or a progesterone support or ABC, XYZ, then a retrochorionic hematoma you may add, expecting that placenta is distorted, destroying, and the pregnancy may need support, additional support early, especially with an early pregnancy.
Thank you so much, Dr. Prashant. That was a lot of new information. Thank you.
Thank you.
So I'll request Dr. Mitra to introduce our next speaker, Dr. Sita Pal.
I have
Sita.
to congratulate.
Hello, sir.
Hi,
Good
Sita.
evening. Thank you.
Sorry, I have to leave. Sorry, I'm in the middle of the clinic. I cannot say no to ICOG any day,
Yes.
and especially when it comes from Chinmay, I have to obey her
Thank you,
orders.
sir.
So that's what I am doing. Thank you very much.
Thank you, sir.
Doctor.
Thank you. So thank you to ICOG, Dr. Sheila Mane and the whole team, Chinmay, Upma, Sheeta, for thinking up of something so wonderful, and you can see the record attendance. And I have the pleasure of introducing my very, very passionate friend for
Thank
fetal medicine, Dr. Sita Ramurthy Pal. I'm
That's
not going to
fine.
take much
That's
time
fine.
because
Yeah.
I want you to come straight to the topic, because
Absolutely.
I think understanding placenta, placentation, and role of color Doppler, and actually defining the fetal growth restriction, that's the $1 million question, which is plaguing all of the obstetricians. And before you start, I just want to say, thank God, placenta is being given the importance the black box gets in aeroplane. So over to you, Sita.
Thank you. Thank you.
Reveal the mysteries of the black box before it's a disaster.
Right. Can you see my slides? Yeah.
Yeah, we can see your slides.
Make it full screen. Make
full
it full
screen.
screen.
Is it full screen now?
No, it's not full
Not
screen.
yet.
No. I think you reshare, Dr. Sita. It's not shared properly.
Yeah. 1 second. Stop share. 1 second. Sorry about that.
It's like a treasure which is there, and without being put to full use. Thank God, importance has been focused on placenta.
Can you see now?
We can still see the now it's full screen. It's full screen.
Thank you. Thank you so much. And at the outset, thank you, Dr. Mitra, for that warm words, and for the entire ICOG, Dr. Sheila Mane, Madam, Dr. Pratik, and of course my co-convener, Dr. Upma, and Chinmay, for this Placentology session and for giving me this opportunity. After hearing these excellent talks, it's always intimidating, especially talking after Prashant sir. But nevertheless, we are going to an important aspect of placenta and the role of how we evaluate this placenta in growth restriction. So that's me for you, and thank you once again for this opportunity. So when we talk about placenta in pregnancy, in the fetus and the blood circulation, we must understand that the deoxygenated blood is carried to the placenta by the umbilical arteries. And then this oxygenated blood actually returns from the placenta to the right atrium by the way of umbilical vein and left portal vein. So the umbilical vein carries the oxygenated blood, and the deoxygenated is carried back to the placenta by the umbilical arteries. But when this to keep the head and the neck vessels and the more important organs have a preferential blood flow, we have a small ductus venosus which flows which produces a steady stream of oxygenated blood that flows through the foramen ovale from the right atrium to the left atrium and then aorta. So most of this oxygenated blood is diverted to the head and neck vessels and the coronary arteries. So basically, when we're looking at the fetal circulation, it's a high rate heart rate circulation with a low blood pressure and a low peripheral resistance. And with advancing gestation, this placental blood flow increases as the arterioles increase in diameter. The peripheral resistance also keeps decreasing with advancing gestational age. Now, when you look at these vessels in the maternal and fetal side, we have the uteroplacental side of the placenta and the uterine arteries with their arcuate arteries. They enter and they supply the villi, and there is exchange of nutrients which go on to the fetus. And in this fetus, the arteries, the vessels which carry these nutrients to, as I said, to the fetus, and that the main arteries that we evaluate is because if there is accumulation of deoxygenated blood in the fetus, and we look at how the baby is compensating. So these are the main three arteries, that is umbilical artery, middle cerebral artery, ductus venosus, the vein, and the umbilical vein. Now, what happens exactly in early gestation is the trophoblast actually plugs in the maternal spiral arteries and it restricts this oxygenated blood flow into the intervillous space. And this hypoxic environment is actually thought to be very beneficial for the early fetal development and placental development. By 6 to 7 weeks, then the whole process of trophoblastic cells starts to migrate, and that initiates a process of transformation from a high resistance to a normal that we see of low resistance uteroplacental vasculature. So the basic biology is that by 8 to 10 weeks, the second wave of trophoblastic invasion occurs, which is known as deep placentation, and that begins to remodel and then epithelialize these spiral arteries, and you have these extravillous trophoblasts that enter the decidua. And all this is mediated by something called by the natural killer cells and some macrophages, and the entire process is completed by 18 weeks. And that is why whatever medication we say, we need to give it before 16 weeks or maximum before 18 weeks. So this is what happens in the non-pregnant state. These arterioles are deeply constricted. The spiral arteries, they get invaded, and then you have the second wave of trophoblastic invasion, which makes them very dilated and supply the placenta. And this gets hampered in preeclampsia and obviously causing growth restriction as well. So in normal placentation, you'll have this multiple villi, very well oxygenated, very well circulated. But in abnormal placentation, the villi reduce, the transfusion, the exchange reduces, and we tend to have early preeclampsia also leading to early growth restriction. Now, there is something called this great obstetrical syndrome, which basically was defined by the Hoffman group, where they said that there's a series of clinical conditions that stem from the failure to achieve these deep placentation and whatever remodeling that happens that doesn't take place. And based on the degree of failure to achieve, they have actually seen different phenotypes that can occur to the fetus, and it can happen anything from preterm labor almost to stillbirth. So if you have a partial remodeling, you have a phenotype like preterm labor, preterm PRM, or you might have growth restriction without hypertension. But if you have absent remodeling, complete absent with obstructive lesions, there are thrombi sitting, then you will have preeclampsia with FGR. You can have even massive abruptio placentae and infarcts with fetal demise. So normally when you look at the features of placenta, we heard Dr. Chitra saying that sometimes these features can tell you. So if it's a thin placenta, all this will be decreased if there is a placental features. And a lot of study has been done about this placental histology, and they found that maternal malperfusion is the major cause of all this problems that happen, and that leads the mother to have placental disorders and the fetus to cause growth restriction. So if you have infarcts, that is seen more in preeclampsia and early growth restriction. You can have retroplacental hemorrhage, villus, abnormal villus maturation. Syncytial knots can be seen, which is more seen in PE and early FGR, and perivillous fibrin deposition. So these maternal malperfusion is supposed to be the key factor in causing early onset placental malfunction, leading to early onset growth restriction. To that extent, fetal vascular malformation which causes thrombus in these vessels, that can cause problems that a sudden IUD may not be related actually to these early onset growth restriction. So when we talk about fetal growth, we know it's a dynamic process and there are maternal, fetal and placental factors. We are looking at the placental factors because whatever happens, fetal growth is a dynamic process, and in placental insufficiency, which is the unfavorable environment, leads to this growth restriction, which can happen very early if there is major placental damage. So Delphi consensus came up with the different phenotypic presentations. We all know that if it presents early, it is less than 32 weeks. That is what is called as early growth restriction in the absence of congenital anomalies. Late, of course, will be taken by Dr. Bela. But there are specific criteria where we measure the fetal biometry. Of course, by checking the dating scan, we know we are sure of the dates. And then when we find that the AC or the estimated fetal weight is less than the third centile, or if it is less than 10th, combined with the abnormal Dopplers, that is either the uterine artery PI is above the 95th centile or the umbilical artery PI is the 95th centile. So there are strict criteria as to how we diagnose early onset growth restriction. And here you can see that the findings are typically in early onset. It is easy to recognize but difficult to treat, as we say, because the fetus is very small. You can pick it up by looking at the lady itself and that her symphysis fundal height, or clinically you can have suspicion. Doppler velocimetry, we will see how that reflects, how it shows the placental damage and how the baby is compromising, the fetus is compromising, and usually associated with hypertensive disorders where the perinatal mortality may be high. Right? So when we're looking at growth restriction, we're looking at the outcomes because we are worried because these fetuses are at increased risk of perinatal morbidity, mortality, and if delivered early, they can have their own prematurity associated complications with worse neurodevelopmental outcome. As I said, when you are assessing the growth, you have to assign the EDD, do the measurements according to the dates, and then you always combine them with Doppler so as to see what the placental blood supply is happening, and especially if there is an abnormal growth, we have to combine with multi-vessel Doppler. So all Doppler modalities are basically, it is a function of the blood flow that we look at. It is an assessment of the blood flow, and it can be, you have different types of Dopplers depending on the moving structures. And then we looked at different Dopplers at different stages of the pregnancy. So when you're looking at placentation, we're looking at the trophoblastic invasion of the spiral arteries, where you can predict the FGR. But when you're looking at, the fetal well-being, then you predict the outcomes or predict how the baby, the fetus is compromising by looking at hypoxemia or acidosis. So the first Doppler that we do routinely is the uterine artery. As I said earlier, because of the research that has shown that these placentae have abnormal, increased resistance in the blood flow, they correlate with abnormal uterine artery changes. And here we look at the pulse wave Doppler. We no longer use the diastolic notch. We calculate the mean PI of the right and the left, and anything above the 95th centile is considered as high risk, which means that this lady is at a potential of developing preeclampsia or developing growth restriction. In association with that, we also depend on other factors, especially if there is a history of a previous growth restricted baby, early onset, or previous history of early preeclampsia. Biochemical markers that we do in our day-to-day practice, that is PAPE 0.4 or less, low PLGF. Even if you do a quadruple test, sometimes high AFP of more than 2 mom, you have to obviously rule out structural defects, but that can tell you whether this baby is at risk. And of course, you have, as I said, these ultrasound markers like uterine artery, as Sir said, velamentous cord insertion, especially in multiple pregnancy, and of course, single umbilical artery. And these are usually predictive for early onset growth restriction. So uterine artery Dopplers, again saying it can predict to some extent, but also if the baby is growth restricted and you find an abnormal uterine artery Dopplers in the 3rd trimester, it does give you an indication that this baby might have abnormal Dopplers, brain Dopplers at term, and these babies are at risk of increased poor perinatal outcome, and the mother is at increased risk of late maternal PET. So when you're predicting outcomes, that was looking at what the cause was. But when you're predicting the outcomes for these babies, especially for these growth restricted babies, we have to look at these Dopplers, 2 artery and 2 venous. One venous. We no longer use the aortic ischemic Dopplers. It's usually the umbilical, mid-cerebral, and ductus venosus Dopplers. As I said, as the resistance in the umbilical artery falls with advancing gestation, these demonstrate a progressive rise in the end diastolic flow. And as we see, the deoxygenated blood is actually getting removed, and when that doesn't happen, these deoxygenated blood gets collected in the fetus and causes problems. So we're here in singletons, as we usually say, we measure the indices in a free loop, but of course in multiple pregnancies, as said, you have to do it at the fetal end or placental end. That would be more reliable, and always use, as we use for growth charts, always use reference ranges for these Dopplers as well. So you will typically see this good flow pattern with a positive end-diastolic flow, and whatever abnormalities that we see, they reflect the amount of villus damage. So anything more than 30% of damage will cause a high PI, more than 60% will cause an absent end-diastolic flow, which means the baby is getting hypoxic. If it is reversed along with ductus venosus, then you will know this baby is getting acidotic. And these can actually predict delivery in the next 4 weeks. So this is a typical cascade of events that happens in early onset. First, your PI will become high, then it becomes absent, and then it becomes reverse. With middle cerebral artery, it is basically it denotes basically cerebral perfusion, but it is never used alone. It is always used as an adjunct to umbilical artery Doppler assessment. So what happens, as I said, if the baby is growth restricted, it is the body's defense mechanism to divert this blood flow as a brain sparing effect, and so the high resistance blood flow in the MCA becomes a low resistance. It does not actually indicate that you need to delivery, because it can be abnormal both in early and late FGR, and so it is not a deciding factor for delivery. Ductus venosus is very important, because as the fetus compromises towards the heart gets starts overloading, and then this is the vessel which tells you what the fetus cardiac status is, and that reflects fetal acidosis. So you, along with the umbilical artery Dopplers, you look at the ductus venosus Dopplers, and it reflects fetal acidosis. So this is the one you're going to look at when you're looking at early growth restriction. So what happens, as I said, in early growth restriction, there is significant villus malperfusion, but the point to note that these Doppler abnormalities may persist for weeks, and that is why we want to carry this baby as much as possible, because every day there is a 2% improvement in survival, especially when you're looking at this very preterm babies. Of course, if these mothers have hypertension along with it, you'll have to take care accordingly as to when to deliver them. So as I said, there is this cascade of events that happens in early FGR, and depending on where they are, you have to monitor these babies as it is. If there is a reverse flow, you might have to see them every 12 hours. That, if it's 26 weeks, you have to talk to them. If it's a reverse end-diastolic flow or ductus venosus PI is high, you might have to do it every day or every 2 days. Or if it's absent, you have to call them twice weekly. And this is the chart that we usually follow. So anything less than 10th centile, or even if the birth weight is less than the 3rd centile with uterine artery PI, they can be markers of compromise, and these are all independent of early versus late. But you must remember, as I said, these take time, so don't be in a hurry to deliver, because even if there is suspicion of acidosis, there is 10 days before anything can happen. That is, if it is absent end-diastolic flow, you can have 21 days before you can deliver the baby, provided you monitor them properly. So don't be in a hurry to deliver them, and early. So the trigger for delivery in early FGR is basically ductus venosus PI more than 95th centile. But sometimes they say that you shouldn't wait. You should wait for ductus reversal, because sometimes high ductus venosus PI can be seen by external factors, or sometimes a compensating fetus. So some people believe that you should wait for ductus reversal rather than deliver when the baby is having a high PI. Obviously, all this has to be a multidisciplinary approach with neonatal counseling, depending on when you deliver them, depending on the parents' wishes and choices, and of course, the maternal condition with max sulf and steroids. So this is a lady who came, just a quick case. She started off at 24 weeks. She came in with an absent end-diastolic flow. She had a high risk anyway. And then we went on in 28 plus 4. It was reversed, but the ductus was normal. So we carried on as well. And then it became reversed. It was still on. But at this stage, 29 weeks, the ductus venosus becomes reversed. So we had to deliver. So in early FGR, the placenta, maternal malperfusion plays a significant role in the pathogenesis. As Dr. Mitra said, pregnancy, the placenta is the black box, so never throw it away, especially in these sort of abnormal pregnancies. You have to send them for histology, you might get a lot of information which can predict the recurrence. So Doppler investigations actually gives insight to this physiology. It can be used as a screening or diagnostic tool to predict and assess hypoxemia and acidosis, but operators should use it skillfully with knowledge of its potential limitations and always use the ALARA principle. Thank you so much for your patient hearing. Thank you.
I think Chinmay, Sita, that was really wonderful. And frankly speaking, I think many of the judgments are taken because of not being very clear about the, becoming panicky earlier or delaying too much. You have to wait. And also the facilities of the neonatal resuscitation. I think the role of a neonatologist and a fetal medicine expert and the obstetrician, this dialogue has to be really, really very good. And like I said, that it's better for us obstetricians to choose very good fetal medicine experts in our city. Otherwise, have friends like you people on the hotline. I never hesitate to send pictures across to all of you all whenever I am in doubt. So that really helps because sometimes you really don't know because you don't want to you don't want to land with acidosis. So I think that was beautiful. You really explained the pathology, the basics so well. Thank you, Sita.
Thank you.
Thanks a lot, Dr. Sita, for a very lucid presentation. I'll now request Dr. Steya Bhuya to introduce our next speaker, who is none other than Dr. Bela Bhatt. I hope Dr. Bela is there.
Yeah, so very good evening, one and all. At the outset, let me thank Madam Sheila Mane and Dr. Pratik, Dr. Chinmay, and Dr. Sita, and the entire team of conveners and coordinators. In fact, it's a very, very important topic, the late onset IUG. I'm sure for the clinicians, the apparently normal uterine artery, when you screen it and you do not label the patient as having high risk, so naturally, inadequate surveillance, I would say, not even cautious about her. And then suddenly you find that there is now something which is slightly less, mild placental insufficiency, and you find that, in no matter of time, that apparently normal fetus landed up into stillbirth. So I'm very eager to listen to you, Bela. How would you take us through this, scenario, and what instructions, I would say, what precautions you would like to give all of us? So over to you, Dr. Bela. Bela is a Vice President-elect, a very dear friend, of course, past committee chairperson for Imaging Committee. Very eager to listen to you, Bela. Over to you.
Thank you so much, Dr. Sneha, for those kind words. At the outset, well, I'm just sharing. Hope my presentation is seen. Is it seen to all?
It is.
Yeah,
Yes.
please go ahead.
Yeah. So at the outset, I'm extremely thankful to the Dr. Sheila Mane, Dr. Pratik Tambe, Dr. Chinmay, Dr. Upma, Dr. Sita for giving me this opportunity to be part of this wonderful series session on placentology. And I've heard a couple of brilliant talks by the previous speakers, and after the talks by Dr. Prashant Acharya and Dr. Sita, who has very beautifully explained about the role of placenta and Dopplers in early FGR, I'm here to talk about late fetal growth restriction, role of placenta and Doppler. So, well, we have several references for the same, and Dr. Sita has already explained about the early onset fetal growth restriction. So, well, friends, out of all early onset fetal growth restriction, 70% are late onset fetal growth restriction. That is the fetal growth restriction that develops after 32 weeks of pregnancy. And the major difference between the early and late is all the severe placental insufficiency which is seen in the early onset fetal growth restriction is not seen in late onset fetal growth restriction because it's a milder disease as far as placental pathology is concerned, and usually less than 30% of placenta is affected, and therefore we will not find severe Doppler changes in cases of late onset fetal growth restriction. Even the fetus wouldn't be very small as you find in the early onset fetal growth restriction. Now, as far as
a diagnosis of late onset fetal growth restriction is concerned, we know that for late onset fetal growth restriction, either the AC or EFW is less than third centile, or two of the three criteria, that is AC or EFW less than 10 centile, ACFW crossing more than 2 quartiles, which I'm going to explain to you soon, or CPR less than 5th centile and umbilical artery PI more than 95th centile. So either two of the three criteria will make it late onset fetal growth restriction. So just starting with the definition, and then we'll go ahead with the placentine Dopplers. So in the growth charts, it's very, very important that we look at if there is a fall in AC or EFW, when it occurs after 32 weeks of pregnancy, then that is what we are supposed to look at. We all know that when we are monitoring the fetal growth charts play a very, very important role, whether it's early onset or late onset fetal growth restriction. And that makes very, very easy for the obstetrician, for the patient, for the fetal medicine to understand how the baby's growth is going on. Okay. And the other very, very important aspect, which is restricted mainly to late onset fetal growth restriction, is growth trajectory. So what do we mean by growth trajectory, and how do we diagnose based on that the late FGR? So if there is a fall in the growth, that is EFW or AC, by 2 quartiles, 1 quartile is 25 centile, and therefore if there is a fall in the growth by 50 centiles, it is also one of the criteria for diagnosis of late onset fetal growth restriction. So just for example, if the growth was at 75th centile at your 22 weeks scan, and at 32 weeks or 33 weeks, if it falls to from 75 to 25 centile, that means the growth is still at 25th centile. It is not less than 10 centile. But because it has fallen by 2 quartiles or 50 centiles, it is also one of the criteria to diagnose late onset fetal growth restriction. And friends, for this, if we are not looking at the growth charts and growth trajectory, we are going to miss the diagnosis. So as we commonly say, it's easier to diagnose early onset fetal growth restriction because of the smallness, because of the abnormalities in the umbilical artery, ductus venosus. It's easier to diagnose, whereas late onset FGR is often missed, and that is because if we do not pay attention to growth charts, growth trajectories, and CPR, which of course I'm going to talk about. So routine 32 and 35 to 36 week scans with Doppler is a must to diagnose late onset fetal growth restriction. And in that, we are supposed to look at the growth centiles, growth trajectory, that is growth chart, and cerebroplacental role, which plays a very, very crucial role as far as late FGR is concerned. Now coming to the cause or the role of placentine late FGR. So, well, we have heard from Dr. Sita that the severe placental insufficiency and infarcts that you'll find in early onset fetal growth restriction, whereas in late FGR, the placental infarcts are very, very minimal. Less than 30% of placenta is affected. And when there is abnormal CPR, it has been found that vascular lesions of maternal vascular malperfusion and venous lesion of fetal vascular malperfusion are there in the placenta. But of course, they'll be, as I said, these findings are less than 30% of the placenta will find these findings. So, histologically, in the late FGR, you'll find that these infarcts are lower as compared to early onset fetal growth restriction. And that is one of the reasons that the diagnosis is challenging, because it is not going to affect the umbilical artery. We know that the umbilical artery Doppler starts getting affected when more than 30% of placenta is affected. Then how do I diagnose? Of course, there is a role of Dopplers, in which out of these multivessel Doppler, that is umbilical, middle cerebral ductus, and uterine artery, in late FGR, it is mainly the umbilical artery Doppler and middle cerebral artery. Now, the normal umbilical artery Dopplers we all know about has a good diastolic flow, and the MCA PI, which has a lesser diastolic flow and normally high PI as compared to the umbilical artery. Now, rather than looking at the separately at umbilical artery PI and middle cerebral artery PI, it is the cerebro-placental ratio which is more sensitive than middle cerebral artery alone. And when the CPR is less than 5th centile, it tells that there is forced centralization due to increased placental resistance and brain sparing effect. And this brain sparing effect is what is important in late onset fetal growth restriction. Now here I would like to emphasize that the umbilical artery PI may not be more than 95th centile. The MCA PI may not be less than 5th centile, but when you take the ratio of MCA PI upon umbilical artery PI, that will be less than 5th centile in many of the cases of late onset fetal growth restriction. And that's the beauty of CPR, to be able to pick up these babies having late onset fetal growth restriction. And so just to emphasize how important this CPR, I'll just quickly share this case. This was a 34 years old primary gravida with conception after 14 years of infertility. Now the patient was seen by me only once, and that was at 32 weeks, 5 days. Now, previous all scans were done by a radiologist or a sonologist. And when the patient came to me at 32 weeks, 5 days, the dating was confirmed based on the nuchal scan, and it was 32 weeks, 5 days for sure. But the growth was at 3rd centile. The Dopplers were, however, normal. So it was advised that it is better to keep the kick count, and the repeat Doppler is advisable after 1 week. Unfortunately, I couldn't see that patient after a week because of some engagements. Again, the patient was seen by the radiologist, and it was mentioned on the report that weeks on ultrasound corresponds with weeks of gestation, and there is no brain sparing effect. However, we all know that this is not how we look at the growth of the fetus. We have to look at the growth centiles. Now, 3 days after this scan, the patient had reduced fetal movement, went to the obstetrician, where the thinking that the uterine shuffle or something is like the bradycardia, fetal bradycardia, emergency C-section was done, and a stillbirth baby of 1.6 kg was born. Now, there is no blame game here, but just I wanted to analyze that after diagnosis of late FGR at 32 weeks, 5 days also, why couldn't we save this baby? So I tried to dissect and find out as to what could we have prevented this IUFD. So I tried to look at all the ultrasound machine findings for in that particular patient. So the scan which was done before 32 weeks, that is at 28 weeks, was reported as normal growth. But when I looked at the growth centiles, it was actually 3.3 centiles, and the AC was at 5th centile. So we know that when AC and FW is less than 10 centile, we are supposed to look at the Dopplers. But Doppler was what was not there. But at 32 weeks, 5 days, when I looked at the growth, it was at 3rd centile. The umbilical artery Doppler was normal. The MCA Doppler was also normal. And so patient was advised to follow up after 1 week. Now, what happens after 1 week? Instead of coming after 1 week, the patient comes at 34 weeks. The scan was done, which reports as normal growth with no brain sparing effect, but the pictures was speaking something else. This is the umbilical artery and the MCA Dopplers. So I compared both the Dopplers at 32 weeks, 5 days and 34 weeks and looked at the trend. So you can see very well here that umbilical artery at 32 weeks to 5 days had absolute normal PI and diastolic flow, whereas within 9 days at 34 weeks, the PI had gone more than 95th centile. Not only that, the MCA PI, which was normal at 32 weeks, 5 days, there was the brain sparing effect, increased diastolic flow, and therefore the PI had fallen from 1.85 to 0.74, which was less than 5th centile. And not only that, when the CPR was calculated, it was less than 1 centile for 34 weeks. So there was brain spanning effect at 34 weeks, and the baby was screaming that I am not well, please monitor me closely, take me out. So what could have been done? At 34 weeks, either we could have steroid and delivered, because we know that these days we have good NICUs where we can save 34 weeks baby, or if at all we want to continue, we have to admit and do daily CTG, because the CTG is the only thing in late FGR which is going to tell us whether the baby is doing well or not. So, well, the role of CPR in late onset fetal growth restriction is so important. In early onset FGR, if the CPR is less than 5th centile, it just tells us that there is good autoregulation and the fetus is able to cope up with the hypoxia by sending more blood to the brain, heart, and adrenals. But in late FGR, whenever the CPR is less than 5th centile, it tells us that we have to monitor closely now with daily fetal movement count, CTG, NST, and BP, because in late FGR, it is the brain stem which is going to be affected by this hypoxia, and even the smallest amount of hypoxia is going to affect this mature brain stem, which is going to get defunct when there is hypoxia. So the trigger for delivery in late FGR is not by Dopplers, but once the CPR is less than 5th centile, we have to monitor with kick count, NSG, BPP, and CTG. And the triggers would be when the CTG shows reduced bit-to-bit variability less than 4 bits per minute, or CCTG is showing less than 4.5 milliseconds, non-reactive NST, spontaneous repeated unprovoked decelerations on NST or CTG are abnormal, BPP score of less than 4. So these are the triggers for delivery. Therefore, if we miss monitoring these fetuses, we are going to have the close to term stillbirth in these fetuses. And well, friends, we have discussed that it is a mild placental disease. So is it that it is less frequent monitoring is required for this because there is mild placental disease? No, we need more intense monitoring in a different manner. That is because these are near to term fetuses, they have reduced tolerance to hypoxemia as compared to preterm FGR fetuses that has higher tolerance to hypoxemia, because these fetuses have relatively high metabolic rate, and therefore even the smallest amount of hypoxia is going to affect the brainstem and is going to cause sudden stillbirth. And friends, out of all the late onset stillbirth, 40% of stillbirths are because of late FGR. So if we are able to diagnose well with the growth charts, with the growth trajectory and CPR, and monitor them well with CTG, NST, BPP, and kick count, then we'll be able to prevent this 40% late the term stillbirths that occurs because of late onset fetal growth restriction. And for that, 32 to 36 weeks Dopplers is extremely important, as I have tried to put here. So, well, friends, the knowledge is a treasure, but becomes ignorance if it's not put into practice. So we must follow these international guidelines and try and help our patients, because aim of each and every obstetrician, fetal medicine consultant is to have a healthy baby in the hands of healthy mother. Thank you so much for patient hearing. Thank you.
Excellent, Bela, as usual, very crystal clear. I think nobody would have any doubts, but if at all any questions, I think we can have it now. From my side, only one question. Yeah, can I ask a
That was
question?
a wonderful talk. That was a wonderful talk, Sita.
Thank you. So
And Bela,
it is
both of you.
mild to moderate placental insufficiency. In spite of that, it doesn't follow that normal routine way, the reduction in uterine artery and then ductus venosus. And in fact, there is a sudden placental failure with severe fetal hypoxia. So why is it so?
So that's what it is, the mild placental disease, but the reaction of the fetus to it is different. Because as I said, it is heart which is affected, which is failing in early onset fetal growth restriction, because of very severe placental resistance against which the heart has to pump constantly, and so the heart fails. Whereas here the heart is absolutely normal. It is the brainstem which is very, very sensitive to even low level of hypoxia, and that causes stillbirth in late FGR. Yeah,
I think, Bela, this is a very, very good message, because what is happening is now that Government of India wants to do stillbirth audit. But the sad thing is that these type of facilities are not available everywhere, and even a proper ultrasound is not done. So, and these are the cases where you will find that the FGR is not diagnosed, and the late onset. Early onset, everybody will be already alert. They know what is happening.
Exactly.
So I think these guidelines, we will have to see that they are included in SOPs when we are doing the audit for stillbirth, and insist on
Yes.
this, that they make the facility like available for these late trimester scans, wherever
Yes, exactly.
is the slightest of the doubt. So if I would like you to, summarize and send me, so that I can, at least in Karnataka government, I can give it,
sure,
So,
ma'am.
because when we are doing the audit, then I think we have to give some message that, yeah, this is the reason, that is the reason. So I think that will be for all the states, because it's happening all over India. So this is a very, very important point. I think all other cases, PIH, health, we all are careful. We know what is happening there. But where we don't know what is happening, I think there we will have to catch them.
Diagnosis is only missed in case of
Yeah,
later.
it is very
And
tricky
the
in later.
routine,
Yeah.
last 5 years almost, we have been doing routine scan for apparently normal fetus between 30 to 24 weeks, because there you can salvage them at the earliest, as we said. We can give Maxilf and steroids, and we can go ahead with whatever intervention necessary.
So very important to do third trimester ultrasound with Doppler. So that we have to emphasize to all our practitioners.
Upama, in your hospital, I have seen that you have a large number of deliveries, How feasible it is in an institute where you have some 250 OPDs every day? And I would like to know, because, yours is a public sector, a government facility. So,
So, madam, in our hospital, what we are doing is we are doing for a TIFA scan around 22 weeks, and we are going for if there's growth restriction clinically, then we go for a scan around 30 to 32 weeks. Otherwise, we are going for a third trimester scan, ultrasound with Doppler, if everything is going fine. Because sometimes we are missing breaches also. They are being induced. So this, and also to diagnose late onset FGRs. So if we find that the baby is not growing fine, then we go for a Doppler at around 30, 32. Otherwise, we do it 36 to around 34 to 36 weeks ultrasound with Doppler.
now, of late, we know that the radiologist, most of the time, the patient gets the ultrasound done outside. The CPR is mentioned. At least, now the patient comes back to us with that report.
But Dr. Bela beautifully highlighted that CPR should not be used, because many a times my residents also keep saying, Madam, CPR uska wo low hai to deliver. So we have to go for CTG and BPP and
No, at least
that should
there
be
is a
emphasized.
For
there is a
diagnosis, it is
suspicion.
important, but for monitoring and trigger of delivery, CPR is not.
Yeah, that's very important because
Suspicious of hypoxia, so the vigorous monitoring.
So they need closure monitoring, not delivery. That should be emphasized,
Yes,
which
yes.
Dr. Bela has beautifully highlighted in her talk.
So the highlight is to not do premature delivery.
Yeah, should not do nitrogen prematurity. Just on basis of CPR. I think now we are at the ending this last session. So I'll request Dr. Dr. Sheila and Dr. Pratik, they want to say something. Hello, Dr.
This was a fantastic masterclass. I think hats off to the organizers, to our conveners, to all the faculty who did an amazing job. All the presentations were evidence-based. They were thoroughly researched. All of the faculty had worked on their presentations. They were not recycled slides from a previous presentation or copy-pasted from somebody else, and they were just reading out the slide. That I think is professionalism of the highest order. I must express my gratitude to all of you for doing more than justice in the short 15 minutes that you had. Hats off to all of you. Fantastic work. Amazing. Keep rocking always.
Thank you, sir.
ICOG rocks with all of you.
Always.
Okay.
Thanks
Anyway,
for the opportunity.
thank you.
So
Thank
much
you
for
all.
the
And
opportunity.
I would like to thank the delegates for such a large attendance. I think
Absolutely, ma'am.
that was
Really,
that was more pleasing.
That's the
Yes.
most major encouragement for all of us.
it was most heartening, ma'am. At one point, we've crossed 550, and even now we are beyond 300 while we are finishing this thing. I think first and foremost, Sheila ma'am, thank you for accepting placenta as a topic, because it was a little offbeat and we were not sure whether it'll even hit a chord. But it's so nice that everybody has revered the placenta and renamed it as a black box and everything. So that was great. Thank you very much, Sheila ma'am, for the opportunity, and we thank Bhaskar sir for making all this happen in this year. We thank Pratik sir, the Secretary of ICOG, for always being a pillar of support for us whenever we are trying to do things. Lots of firefighting happens behind the scene when something has to be put up on stage. My co-conveners, Dr. Sita and Dr. Upma, thank you very much for always being there. And on behalf of all of us, we would again want to thank the ICOG office as well as all the delegates and faculty. A special mention to, of course, Nilima, who's always been there and doing everything for us all the time, and the Albert David team, which had given us the support as academic partners for this program. And they have also promised to, give us more support with regard to the placenta book, which was published. Sheila ma'am, I hope you would want to make a note about it, that we are going to circulate that book to all our members.
One more
Dr.
thing.
Dr. Chinmay, Dr. Lakshmi wants to, Dr.
No, I just want to, because people are leaving one announcement. The certification course is going to happen on 24, 25, and 26, because somebody is asking. Okay. And those last two slides also, Pratik, which we wanted regarding the
Nilima, if we
conference
can please
and
share. Before people log out, we should have
before
that
people log out, I wanted those slides. Anything, Chinmay, you can add? The slides will be projected.
Yes, ma'am. Nilima has that. Nilima?
So just to announce that the ICOG convocation is now held twice a year, always at AICOG as earlier, and of course at the annual conference of ICOG, which this year happens to be in Bengaluru, 22nd and 23rd of August. All of you who are eligible to become fellows would highly recommend that you please go online to our website, click on the link, look at the eligibility. If you are, please do submit as early as possible. We'll be assessing all the applications. And of course, those of you who are deemed eligible will receive the fellowship at the ICOG convocation in Bangalore.
So next month we have a masterclass on adenomyosis and hysteroscopic management of adenomyosis. We have 2 international speakers coming for that program, and
that's on World Health Day, 7th of April.
Yeah, 7th of April, 9th we will have a Guru Mantra, and we also have a certification course on mental health with RCOG. And we are trying to look forward to get faculty from NIMHANS, which is a very renowned institute in Bangalore. So Dr. Prabha Desai, who is the director of NIMHANS, is also involved. So I think mental health is very important today. So it will be on mental health. Thank you.
Thank you, ma'am. Thank you very much for all your blessings and guidance.
Thank you, everyone.
Thank you. Good night.
A very good evening.
Thank you, everyone.
Okay. Thank you, everyone. Bye-bye.
Bye-bye.